Hello and welcome to Trial TV Live. I am the Squeegee of Justice. Thank you so much for joining us today as we are continuing our coverage and our look into the Carlos Dominguez trial. We are going to take a look at the cannabis expert testimony today. Yesterday we heard from the state talking all about Carlos's cannabis use, and let me just make sure my audio works. We heard all about his cannabis use yesterday from his roommates, from his dealer. Today we're going to hear a expert testify as to the effects on cannabis and your brain, and so I'm looking forward to that. So we got about 3.5 hour stream for you guys. So settle in, get comfortable, and let's get started. All right, welcome in, everybody. Welcome in. Thank you so much for joining us for this stream. We are going to be taking a look, as I said at the top, at the cannabis experts and how it affects the brain. It is Dr. Steven Siegel. So let's get right over to it. No sense in wasting any time. So this is Dr. Siegel taking the stand, and let me find out. So this is from June 26th. So let me just come over here and see what Dr. Siegel. All right, so this is from June 26th, and this is Dr. Siegel.
And have the clerk administer an oath. After you take the oath, our witness stand is right here. Thank you. Thank you.
You do solemnly swear the testimony you're about to give in the cause now pending before this court is the truth, the whole truth, and nothing but the truth?
Yes. Go ahead and have a seat. Good morning.
State your name and spell your last for the record.
You could state your name and spell your last.
My name is Steven Siegel, and that is spelled S-I-E-G-E-L.
Okay, thank you. Go ahead and pull yourself into the microphone, and you'll be comfortable that way. All right. So, Mr. Hutchinson, this is direct examination of the defense.
Good morning, sir.
Good morning.
What is your occupation?
I am a psychiatrist. I am also Vice President for Behavioral Health at USC, University of Southern California, Chair of the Department of Psychiatry at USC, and the Chief Mental Health and Wellness Officer for Keck Medicine of USC.
What is a psychiatrist?
It's a branch of medicine that studies emotional and psychological illness and state.
Are psychiatrists medical doctors?
Yes.
Can you describe your educational background that ultimately qualified you to become a psychiatrist?
So first I went to Colgate University from 1982 to 1986, majoring in neuroscience. Subsequently, I did a medical degree, or an MD, and a PhD at Mount Sinai School of Medicine, focusing on neurobiology. After that, I did a residency in psychiatry at the University of Pennsylvania, followed by a fellowship in neuropsychiatry with focus on the neurobiology of schizophrenia, also at the University of Pennsylvania. And then I joined the faculty there in that role.
Let's back up. You earned your bachelor's from Colgate in 1986. When did you earn your PhD in neurobiology?
In 1994.
And that was, you said, at Mount Sinai School of Medicine?
Yes.
And when did you earn your MD?
1996. You do them concomitantly in something called the Medical Scientist Training Program, so you go back and forth. 2 years here, 4 years there, 2 years there.
So you sought your MD and PhD at the same time?
Yes.
What was your purpose in doing that?
I wanted to understand how illnesses occur, their basis, study their etiology, their treatment, and bring that knowledge into therapy so that I could inform and hopefully improve treatment of schizophrenia.
You mentioned that after you finished your residency and fellowship, you had academic positions. What academic positions have you had?
First, at the University of Pennsylvania in Philadelphia, I joined the faculty as an assistant professor on the tenure track. Then I received tenure as an associate professor, ultimately then became a full professor of both medicine and bioengineering, after which in 2000, and I was there in the faculty role from 2001 to 2016. In 2016, I moved to USC, University of Southern California in Los Angeles, where I became the chair of the Department of Psychiatry, also full professor with tenure in both medicine and bioengineering. And then subsequently got the additional roles. In 2021, I became the head of all mental health for the entire health system, and then in 2024, I became the head of mental health and wellness for the entire university.
So in your current role as head of mental health and the chair of the Department of Psychiatry, do you have responsibility for supervising others?
Yes.
How many people are technically under your supervision?
About 450 across the different roles.
Okay, what are those different roles?
So as chair of psychiatry, we have approximately 165 faculty members, 100 trainees, and about 100 staff. In the role of chief mental health and wellness officer, I oversee an office of 9 individuals separate from the psychiatry department, and then in the role of vice president, I oversee an office of 11 people presently that have, again, non-overlapping population with the other 2 jobs.
What clinical positions have you held?
So actually starting all the way back at University of Pennsylvania, so the residency is a clinical position. You're training to become a specialist in a medical field, so I could think of that as a clinical position. But then once I joined the faculty, I was an inpatient schizophrenia psychiatrist. So for 5 years I was on an inpatient psychiatry ward. I've had an ambulatory care, an outpatient practice focusing on schizophrenia since 2000. Actually, since residency, but as an attending, right, the doctor in charge since 2001. I've covered consultation liaison services for many hospitals, University of Pennsylvania, Keck and Norris hospitals, Arcadia Hospital, where you do psychiatric consultations on medical and surgical patients. And I've been an inpatient attending at the University of Southern California at the Augustus Hawkins inpatient psychiatric unit, which has about 60 inpatient beds divided between adults and children.
And just to clarify, when we talk about clinical experience, that is actually treating patients?
All of that was treating patients, yes.
Have you also conducted research?
Yes, I've had, no, please go ahead.
So don't have to go into all of them, but what major areas of research interest do you have?
There are two major areas. One has been studying the basis, the mechanistic or basic pathophysiology, the cause and way that schizophrenia manifests in the brain. And we study genes, we study environmental exposures, and we look at how brain circuits form and function for things like cognitive function or social function. And that's a big part of my lab. It's been funded by the NIH and multiple organizations. The other half of my lab is the bioengineering, where we focused on drug delivery systems, and my lab invented the biodegradable polymer system that's used in a current schizophrenia treatment, something called Uzedy, that allows patients to get a shot once every 2 months and stay in treatment. And that delivery technology came out of the bioengineering half of my lab.
We're going to get this a little later, but are some people with schizophrenia treated with a monthly injection or bi-monthly injection?
Yes.
We'll come back to that later. Have you conducted any research in adolescent drug abuse?
Yes.
And how many peer-reviewed publications have you authored, either as a sole author or as a co-author?
It's probably at about 160. There have been a few more this week.
Okay. What is a peer-reviewed publication? What does that mean, peer-reviewed?
It means that you submit to a journal, and the journals have different tiers that are quantified by how competitive they are and their impact. Those, the initial phase means that the editors will decide whether it's even worthy of peer review. If they deem it is, based on quality and relevance, they will send it out to generally 3 experts in the field who are deemed to be qualified in that specific area. Those individuals write a comprehensive review of the manuscript and send it back, at which point the editor will either decide to reject or allow revisions. You do that again, and if it's accepted, that's how you get published in a peer review journal.
Dr. Siegel, before I get to my next question, I'm going to ask you to give us some definitions. When we use the term diagnosis, what does that mean?
It's the name and the sort of definition, the criteria for reaching a specific disease as it's recognized in medicine. So, as an example, if someone has asthma, right, they meet specific criteria for that disease, as distinguished from just difficulty breathing.
The term etiology, the etiology of the disease, what does that mean?
That's the cause. And so, again, using that, an example like that, you might say the person has a mass, right? That would then go on to have a name of a specific kind of tumor, and the etiology of that tumor might be a genetic abnormality that leads to abnormal cell growth.
And when you speak about the pathophysiology of a disease, what does that mean?
That is how it's manifest, the things that are going awry. So I'll use an example, heart disease, right? You may say that the disease is coronary artery disease. The pathophysiology the pathophysiology would be there's plaques or buildup of cholesterol and other factors that are blocking the arteries. The etiology would be any genetic or environmental factor that led to the buildup of those blockages in the artery.
And finally, I think most people are familiar with this term, but when we talk about treatment of a disease, what does that mean?
It's an intervention, and it can be pharmacologic, meaning medicine or non, that alters the course of the disease to reduce the burden of the disease, the symptoms and the morbidity.
Dr. Siegel, based on your training, experience, do you have expertise in the diagnosis, etiology, pathophysiology, and treatment of serious mental illnesses, SMIs, including schizophrenia, schizophrenia spectrum disorder, and bipolar disorder?
Yes.
And do you have experience and expertise in the diagnosis, etiology, pathophysiology, and treatment of substance use disorders, including cannabis use disorder?
Yes.
And finally, sir, do you have experience and expertise in substance-induced psychotic disorders, including cannabis-induced psychosis?
Yes.
At this point, I'd like to offer Dr. Siegel as an expert.
No objection?
No objection. I think we can tailor the parameters later.
Qualified expert. Thank you. Go ahead.
Dr. Siegel, have you ever personally examined Carlos Dominguez, the young man seated to my left?
No.
Have you ever seen him in person before today?
No.
Okay. Sir, have you reviewed any case-specific materials in this case, such as police reports, transcripts of prior testimony, medical records, or case-specific reports of other psychiatrists or psychologists?
No.
Okay. What, if anything, have you reviewed in connection with this case?
The linkage, the potential links or lack thereof between different etiologic factors and schizophrenia.
Let me be more focused on my question. What materials in connection with this case? Were you provided with some journal articles? Were you provided with some journal articles that had been provided by the Yolo County District Attorney's Office?
Yes.
Okay. Approximately how many of those journal articles did you review?
60, 70?
Were there more articles that you did not review?
Yes.
Did you apply any criteria to limit it down to the relevant articles to review?
I did.
What was that criteria?
I looked at whether they were peer-reviewed or not, because that's a level of quality control. I then also applied a standard, as I mentioned earlier, there's something called impact or impact factor, where journals are given a quantitative number. So it's not just like good, bad, it's actually a number like 5, 5.2. And that number imparts how often those articles are read and cited, and an impact factor above 4 really separates articles that are not particularly important or good from ones that are better, and then you can use that graded scale to go from good all the way to great. But above, I looked at ones that were above an impact factor of 4.
And what about case studies? Just articles speaking about a specific case or a few specific cases. Are those particularly relevant in your opinion?
No.
Why not?
They're anecdotal and speculative, and they don't apply the rigor of trying to decipher cause versus correlation, and they can't distinguish impression from data that support a conclusion.
Look, you mentioned two terms, cause and correlation. I'm going to ask about another term, association. Oftentimes articles, they're looking at an association between certain things. What does association mean?
There are two things that happen sort of at the same time or in the same place, and they either have they go up or they go down or they go in different directions, and it seems like those are happening in a way that is similar.
And what does the term correlation mean?
It's a little bit more specific if it's used in a scientific term, because you can put a number on it and determine how well movement along one dimension correlates with, or not to use that word, has a predictive value for the other parameter. So if you think of a chart, you might say that the first parameter goes up, the second parameter goes up, and then you would see the relationship as kind of dots, individual things. And the more that those things travel together, the higher the correlation. So you can put a number on it.
Sir, does correlation or association, is that necessarily equal causation?
No.
Okay, why not?
There's a lot of things that travel together but have nothing to do with each other. They're just caused, for example, by a second thing or a third thing that is related to each of them, but those two have no relationship to each other.
Let me give you an example. Would you agree that in summer months, both ice cream consumption and drownings would go up? Would you agree with that?
Yes.
So there's a correlation.
Yes.
But based on that, would it be proper to infer that ice cream is causing drownings or vice versa? You can answer.
No, those things are not causally related. They're just associated or correlated.
Now, have you reviewed any case-specific reports or case-specific section reports written by any of the other psychiatrists or psychologists involved in this case?
No.
Okay. Did you review a non-case-specific portion of a report written by Dr. Torrey, Dr. Zachary Torrey?
I did read reports by Dr. Torrey, yes.
Was it, and by case specific, I'm referring to like details about the case. Was that a section of reports where Dr. Torrey just spoke about schizophrenia and cannabis seriously? Was that a section of the report where he just spoke about schizophrenia and cannabis-induced psychosis in general?
I can look at my notes. My recollection is that mostly it was in general. And thinking back over, I don't remember reading something about the young man that's in here.
But beyond that section of Dr. Torrey's report, have you reviewed any other reports written by any other experts in this case?
No.
Sir, in your testimony today, will you be offering any opinion whatsoever as to whether Carlos Reales-Dominguez does or does not have a specific mental health diagnosis?
No.
Why not?
I haven't interviewed him, and I don't know anything about him personally.
As a psychiatrist, can you diagnose someone you have not examined?
No.
Sir, what is schizophrenia?
So it has a definition as laid out by the American Psychiatric Association, and it's a constellation of several symptoms, chronicity, timeline, and function. The first criteria is that someone must have a subset of what are called positive and negative symptoms, positive being things that are present in the individual but should not be. These include hallucinations, false sensory experiences. And because this can sometimes be confusing, I'd like to be a little more verbose here. A hallucination is hearing, seeing, feeling, indistinguishable from whether there's a real person or stimulus there. So it's not thinking a voice, it's hearing a voice.
Let's break this down step by step. You mentioned positive and negative symptoms. Obviously, it's not because one is good, one is bad, correct?
It's present and absent.
Okay. Let's talk about positive symptoms. You mentioned hallucinations. And you provided a portion of the definition. Explain what a hallucination is.
So it's a false sensory experience. The person actually hears, sees, feels, smells something that isn't there. The way we think about that is you have an external sensor. In the case of hearing, you have an eardrum. It goes through a series of little bones. It stimulates nerves in something called the cochlea, and that starts neural activity into the brain, which is then highly organized and interpreted. One can imagine that neural activity could start somewhere along that path and be perceived as if it had come from the outside. So a hallucination is the perception of a stimulus, sound, smell, touch, taste, in the absence of an external stimulus.
What are other positive symptoms of schizophrenia? Let's take them one by one.
So delusions, and a delusion is a fixed, false belief outside of someone's cultural background. And we break those down into ones that are bizarre and non-bizarre because that has slightly different significance. So an example of a delusion that is non-bizarre is one that is technically possible but highly unlikely. This would be an example of someone saying, I feel like, or I believe that when I go into public places, someone is listening to me all the time. There's microphones or cameras, and I feel like I'm under constant surveillance. It is highly unlikely that that is true of that individual, but technically that exists. So that alone wouldn't be enough. You'd need a few things to go with it, like hallucinations and some of the other things. A bizarre delusion is one that is not possible. So that same person would say, I believe that when I go into public places, my thoughts are being transmitted to satellites because a dentist put a transmitter in my tooth when I was young. Those satellites are transmitting the signals to the monitors, and everyone in the room is seeing my thoughts. So that would be a bizarre delusion, one that comes up from time to time.
And even though a healthy person would never believe that, do people with schizophrenia believe their delusions? And
that is really the definition. It's an unflappable belief that this is the case despite everybody else's opinion or evidence to the contrary. That's why we call it a fixed false belief. It can't be that you say, I think today's Tuesday, and someone goes, hey, here's a calendar, and you go, oh, I'm sorry, I was wrong, it's Wednesday. Right? It was false, but you modify it with data.
What are other positive symptoms of schizophrenia?
So disorganization, which is the lack of structure, and you can think of that for speech or for behavior. So for speech is probably the best way to demonstrate it, and so a disorganized pattern of speech goes along a gradient. At the mildest level, we talk about, or we categorize that as something called circumstantial speech, where you ask a question and the person goes in a very roundabout way to get there. So it's mild thought disorder, mild disorganization. At the next level, it would be called tangential. So you ask a question, they start in the right area, and they just go off on a tangent and never come back. At a more severe level, so here you can say the concept isn't well organized. The next level is that the sentence isn't well organized. It'd be words that are in there, real words, but they don't seem to fit. So I might say, how did you come to be here today? And the answer would be, while traveling, a girl, boat, small shoes, and socks. So the words, and then at the final level, we actually use the term word salad, where the actual letters don't even form words, and you can't really comprehend what the person is trying to express because there's such disorganization that even the letters don't form words.
You mentioned disorganized speech. Is disorganized behavior also a positive symptom?
Yes, and that can be purposeless movements like picking, or it can be just kind of ruffling through things with no apparent purpose. but it's essentially that same construct that you lack the organizational structure that is part of normal daily life.
Are there any other positive symptoms of schizophrenia?
Those are the big ones. Yeah, those are the big ones.
What are negative symptoms of schizophrenia?
So this is lack of things that should be present. And so for this, the first and most obvious one is emotion. People with schizophrenia often describe a lack of emotion, which can be confused with depression. And the distinction is if someone says, I'm not happy, the follow-on question in that exam is, well, are you sad? And often the answer is no, I'm just kind of here. And so there's a lack of perceived, felt emotion. There's also a lack, or again, all on graded scales, a lack of expressed emotion. And so we look at facial expressions or use of gestures, and what you see is a very restricted face. We can call it a mask-like face or a Parkinsonian face, looking like someone with Parkinson's disease, where the person can say, oh, I am happy. And there's no smile, there's no contact, there's no light in the eyes. So a restricted expression of emotion and a restricted perception of emotion.
Is that a restricted expression of emotion? Is that referred to as a flat or blunted affect?
That is the term. It's a flat or blunted affect, and then I use the terms for gradations of that.
Does the fact that a person with schizophrenia may not be expressing emotion, does that mean they're not feeling emotion?
It can, but it doesn't have to. Sometimes, as I alluded to, someone will say, oh, I'm happy. And you just can't see it. Other times they'll say that they don't feel happiness, and then if one there's lack of anticipatory happiness. As you say to someone, we're going to go to a party later today, will you have fun? And they'll say, no, I won't. But if you ask them at the party, they're actually having fun, but then the next time you do that, you'll say, well, you went to a party, you told me you were having fun, we're going to go to another party, and you go, no, I won't have fun.
So we talked about lack of emotional expression. What are other negative symptoms?
So lack of social affiliation. People will not feel the need to be around others. And again, all of these things vary. And then there's lack of motivation, lack of sort of movement and inertia. So these are all the A's. Avolition, asociality, anhedonia, lack of emotion.
Let's take them one by one. Okay. We'll start with the A's.
Yeah.
Okay. Now you mentioned abolition. I've heard it pronounced avulsion, abolition. Which one is it in your expert opinion?
I would have gone with avolition.
Okay. So what is avolition?
It's people just don't do anything, and they won't have initiative. They won't have purposeful or meaningful movement towards things. This is the example with someone with that. You say, well, what do you do all day? I sit at home. And what do you want to do? Nothing. And does that bother you? No.
Can this lack of motivation in people with schizophrenia lead to a decline in personal hygiene?
Yes. And yes.
Can you explain?
And it's more than just a sort of a sensory thing. As an example, there is evidence that people with schizophrenia have reduced sensory smell, a reduced sense of smell. And sometimes people will try to link that and say, well, they didn't shower because they can't sense it. And as a clinician who's worked with hundreds of schizophrenia patients, I always say, really? Is that how you, whoever I'm talking to, is that how you make a decision to shower in the morning? Is you kind of go like, yeah, I'm due? No, it's part of your general sense that you're supposed to shower every day, right, to be part of society. And many patients with schizophrenia just lack that social awareness that hygiene is part of the contract that we have with other people in society.
Can this lack of motivation also lead to an inability to care for themselves or others that they were previously responsible for caring for?
Yes, and in May I use a clinical anecdote that's emblematic of that?
Yes.
One of the patients I took care of when I was at Penn, I think, was a typical yet very poignant example where when he would come off of his medicines, would stop self-care, and the last time that happened, when he went off his medicine and stopped caring for himself, the police report in that case described him as lying on the highway. Encrusted in his own urine and feces, freezing on the highway.
And this was a patient you treated?
Yes.
So that's obviously care for oneself, but obviously we have responsibilities to care for others, children, pets. Can schizophrenia affect a person's ability to do that? It can, and it can affect it is a good way to say it. So that's abolition. What is the other A you mentioned?
So, asociality.
What's asociality?
This not having the, what we consider normal desire and need to interact with other people.
And what is anhedonia?
That lack of or reduced sense of emotion.
How about inability to maintain eye contact? Can that be a symptom of negative symptom of schizophrenia?
It is described as one of the common symptoms of schizophrenia. I think it's part of the asociality component.
So it would be fair to say some of these negative symptoms, they overlap?
Yes. And as you can imagine, if you're not motivated and you don't do things, it's hard to separate those, right?
What about thinking? Is concrete or simplistic thinking, can that be a negative symptom of schizophrenia?
It's more in what I would call the cognitive domain, and I'm not. There may be other people would put it in that domain. I think of that almost as a separate domain, which is the cognitive limitations in schizophrenia, and there's overwhelming data, although it's not part of the DSM. There's overwhelming data that says that people with schizophrenia show significant cognitive decline, and as part of your cognitive profile, one of the hallmarks of schizophrenia is the inability to be abstract. So very concrete thinking. And the typical exam question is you would say to someone, what does the phrase "don't cry over spilt milk" mean? And the answer you expect is it means don't think about things that have passed, focus on the future, don't dwell on things you can't change. Whereas someone with extreme concrete thinking would just repeat back that, if the milk's spilled, there's no reason to cry. And
what other based on your experience, cognitive limitations that people with schizophrenia experience? And
I would go beyond my own experience here and talk about the data that's in the literature from high-quality peer-reviewed studies.
So and your experience and your review of the peer-reviewed studies.
Thank you. So when we look at a cognitive profile, there's many domains of cognition. There's your long-term memory, your immediate memory, spatial memory, verbal memory. These can all vary. And one can imagine I might have a great ability to recall things that happened years ago, but I might not be great at manipulating a map. And so that neuropsychological profile of all the different domains can be graded using what's called a normal distribution, which is, there's a mean, and then there's the amount that people vary. Most people are familiar with this in the sense of an IQ test, right? There's a mean, there's a distribution, and everybody falls somewhere on that. When you do that for the different cognitive domains, you can look at the distance a population is from the mean. So, for example, in an IQ test, by definition, 100 means, that's what it means. It means the mean. The average score right in the middle is 100. You then look at what are called standard deviations. So these are units that are 1, 2, 3. And each standard deviation is a proportion of the population on that distribution curve that looks like a bell-shaped curve. By definition, if you go 2 standard deviations to the right, numbers get higher. Each one of those is 15 points. And so an IQ, because this is a construct I think most people are familiar with, of 130 is 2 standard deviations, 2 units of 15 points. And that would mean that anyone below that, that's 97.5% of the population, above that number is 2.5% of the population. In the other direction, 2 standard deviations below the mean. So again, you go from 100, 15 units is 85, 15 more is 70, right? Because you have 30 units. Now, 97.5% of the population is above that score. Only 2.5% of the population are below. And 70 on your overall IQ is the operational definition of intellectual disability. Below a score of 70 is intellectual disability. So now coming back to schizophrenia, people with schizophrenia are generally, as a population, 2 standard deviations below the mean on each of those cognitive capabilities, suggesting that as a population, they have moved to significant impairment across multiple domains of our ability to think and manipulate
Let me
data.
ask you a follow-up. You're referring to people who have schizophrenia. In your experience, have you treated many people with schizophrenia who, prior to becoming sick, were very high functioning and had high intellectual capacity?
Yes.
And so the disease changes that. Is that?
It does, and there's, I think, good evidence that it's a shift of about 2 standard deviations. And so you will find very high functioning people with schizophrenia. It's rare, it's very rare. But when that happens, the important question is, well, how were you doing before that? And so if you find someone who's functioning normally in society, maybe even a little above normal with schizophrenia, those are the people you'll often go back and say, well, this person was the valedictorian of their high school, maybe they were even at the top of their class for the first 2 years of college at a really good college. Then they started doing kind of average. By the end of college, they were just getting by, and now they're struggling to just function in society better than many, better than most people with the disorder, but it's only because they started so high.
So it's kind of 2 deviations from where you started.
Is how I experienced it with the patients that I've worked with, yes.
Can schizophrenia affect how a person moves or their posture?
Yes, it is actually a motor disorder, and I think that a lot of that gets ascribed to the medicines that people take, but there's really, I would say, incontrovertible evidence that in the absence of medicines, schizophrenia is also a motor disease. I think that's been understudied, underappreciated. But there's at least one very, very high-quality review that goes through the literature by someone named Wayne Fenton, where he documented clearly that populations of people with schizophrenia who had never been on medicines had these motor abnormalities. People without schizophrenia who were put on the medicines don't develop those motor abnormalities, and that the motor abnormalities increase as a function of time, such that it's very rare early in the disease, but late in the disease, a very high proportion of people with schizophrenia have motor abnormalities.
Okay, so these motor abnormalities, abnormalities often begin later in disease? Is that what you said?
It increases the proportion of people with schizophrenia who manifest these overt motor symptoms, just increases with age.
What type of motor symptoms might you see in a person with schizophrenia?
So there's the name of the motor disorder that I was describing is called tardive dyskinesia. Dys means abnormal, kinesis is movement, like kinetic. Tardive is like tardy. So tardy, late, dys, abnormal, kinesis, movement. So it's a sort of late onset movement disorder or a progressive movement disorder that happens over the course. So that's one type, and that's abnormal lip smacking, maybe movement of the hands. It's a disconnect, an abnormal movement. There's also a more general, harder to quantify discoordination or a lack of coordination where people, you might say they're just uncoordinated or they're awkward. But there's a movement pattern among people with schizophrenia that, while harder to quantify, if you've interacted with a lot of people with schizophrenia, you can sometimes just be on the street and say, that person may have it based on how they're moving.
Have you seen people with schizophrenia who have kind of rigid, unusual postures?
Yes.
Now, previously, was there a diagnosis of catatonic schizophrenia? Did that used to be a diagnosis?
Yes, and technically it can still happen. We tend not to use those terminologies as much anymore. I think they weren't as useful. These different kinds of schizophrenia didn't really have the prognostic and diagnostic significance that they were thought to have maybe 30 years ago. But catatonia, in general, is the lack of movement. And catatonic schizophrenia is someone with schizophrenia who really doesn't move much or at all.
So people with schizophrenia, some people can exhibit catatonic symptoms. What examples would those be?
So it's not restricted to schizophrenia. It can happen in schizophrenia. It can also happen in severe depression. And you can think of it as the person's wide awake, listening, perceiving, but not moving. The anecdote, the story that is most emblematic would be, and I've had this one, in the emergency room, there's a patient there brought in by family, they're lying on the gurney in the ER and they're not moving, and the staff start talking about them like they're not present, and you have to say, he's listening, he's not reacting, he's not moving, but when we get him to move later, because there's some treatment, he's going to repeat back everything you said.
So why is it for healthy people trying to sit motionless for long periods of time is uncomfortable, but some people with schizophrenia can do that? What causes that?
I'm sorry, I don't know the pathophysiology or etiology of catatonia. The best I can do is say there seems to be an engagement or an involvement of the neurotransmitter dopamine.
You can finish.
Can you restart that?
Yes. While I don't know the specific cause, meaning etiology and pathophysiology of catatonia, there is a neurotransmitter called dopamine that is very much involved in schizophrenia. Increasing dopamine can lead to psychosis. Medicines that treat psychosis decrease dopamine binding. Diseases with decreased dopamine, like Parkinson's disease, cause motor abnormalities, and medicines that block dopamine receptors, specific medicines that block dopamine receptors, can cause movement changes like stiffness and lack of movement, suggesting that abnormalities in dopamine synthesis, making it, or its ability to bind receptors, meaning how it acts in the body, can impact movement in ways that look very much like Parkinson's disease or catatonia.
And is distrust of others, is that a symptom of schizophrenia?
So persecutory ideation, what we think of as paranoia in the normal way of talking, is one of the, it's not always there. It's not necessarily pathognomonic for the disease, but it is very common in the disease to have persecutory ideas or delusions where you think other people are doing something to you or about you.
And so we're going to get to the criteria, but not everyone with schizophrenia is going to have all these negative symptoms. Is that correct?
That is true. Not everyone with schizophrenia is going to have all of those symptoms. Nobody with schizophrenia is going to have all of those symptoms.
Now, I want to ask you some other questions. Do people with schizophrenia sometimes exhibit what might be described as obsessive-compulsive type behavior?
It can happen, and there can be overlap with a different disorder, a different diagnosis of OCD, obsessive-compulsive disorder. And so in distinguishing those two, you would use all those other criteria, right? So someone who had an obsession about, use a common one, cleanliness, and a compulsion that they have to therefore do things to remain clean. If they're going to work, they have function, they don't have hallucinations, they don't have other delusions, it's just that one thing. That person would have OCD, right? But a person who had a delusion, if I don't close the door 3 times, then the world will be destroyed. So that's a kind of an OCD-like cause and effect, but it has that one bizarre nature in that example. And if it's part of a constellation of hallucinations, the delusion, all the A's that I mentioned, the lack of function, and we didn't get to it yet, but there's a criteria called chronicity, right? Time. If you have these things for a day, you don't have schizophrenia. If you have them for a week, you don't have schizophrenia. These symptoms that we've talked about, the positive, the negative, the cognitive, they have to last 6 months or longer in order for someone to say, okay, now I've ruled everything else out, this has gone on long enough, this is schizophrenia.
We're going to get to that with some later questions. But I want to ask you about another disorder. What is schizophrenia spectrum disorder?
So that's what we call it when you haven't met all the criteria for long enough. It says, this is looking a lot like schizophrenia, but I haven't met all of my diagnostic criteria yet where I feel like I can make this diagnosis with confidence. So
is that kind of an umbrella term that covers many potential or other potential psychotic disorders?
Yes, and the basis of that is until you've established that chronicity, it's not a random thing that people made up like, hey, let's just set 6 months. It's based on the idea that that's how long it can take to rule out all the other things that can look like schizophrenia, but may have a different etiology, they may have a different time course and prognosis, what's going to happen later. But that sorts itself out here in only 6 months.
Sir, what is the typical period of onset for schizophrenia? When do people generally get sick?
So there's really two ways of answering that. They're related, but it's important. So the first is when the diagnosis is made, the day that a doctor says, Mr. Smith, you have schizophrenia. It's you can think of that as when someone's gone through that whole process and they've looked at 6 months of function and symptoms, and they make that. But if in that same time you say, okay, to Mr. Smith's parents, Mr. and Mrs. Smith, when's the last time Joey was normal? They say, what do you mean? I say, well, not like he is today, but when did he have friends? When was he doing fine in school? When did he go to football practice? When you think back, when was the last time your son was really the way that you expected him to be? and it'll be like 3 years. And in fact, the data are that it's 3 years from what's called the onset of a period we call the prodrome before the expression, the full expression or diagnosis. And again, this has become a very well-studied area. There's, at this point, hundreds and hundreds of studies all over the world looking at this period of time when people go from at-risk, prodrome, having one or two symptoms, what you can think of as things that may be predictive of, but they haven't met criteria, and it's generally 3 years. So when you look at the person who had schizophrenia at 18, it's generally around 18 to 24. When that happens, what you really learn is that it's more like they fell off the curve, they fell off their normal developmental trajectory at 15 to 21.
So schizophrenia begin at the point of diagnosis, in your opinion?
No, and some people would argue, it begins at probably pre-birth, and there's so the expression of schizophrenia is extraordinarily rare before puberty. It's slightly less than 1 in 100 when you have onset in that post-pubertal period with diagnosis in the 18 to 24, but falling off function 15 to 21. That happening before puberty is 1 in 10,000 people. So there seems to be, there's something in your genetic makeup that's there, but it doesn't come out until later. But many people would argue it's been there latent since birth.
And you said 18 to 24. Is that for men? Is that the typical period?
It's a little bit different in men and women. You might say 18 to 24 in men. It might be 20 to 26 in women. There's a slight delay and slightly less severe symptoms or less severe manifestations in women as a population.
So, you gave the example of Joey being diagnosed, and then you look back 3 years, and you describe that could be the prodromal phase. Looking back, what sort of symptoms, in retrospect, can you see that you may have actually been emergent symptoms of schizophrenia?
So there's both what we call signs and symptoms, right? So there's things that people are doing that they're experiencing that you can see. There's also things you can measure. So before this was a very active research field, which now has been probably 15 years. Before that, you would have said, well, the things that happen is, they fall off the curve cognitively, they stop having as many friends, they may have more behavioral problems at school, they may act in ways that begin to, they're more isolative, they have stranger but not yet bizarre thoughts. When we then layer on the level of research rigor, there's EEG, electroencephalographic, and this is my area of research, this is what I study, is electroencephalographic changes. You put electrodes on someone's head, you can measure brain activity, you can do that at rest, or you can present stimuli and measure how the brain, the neurons, the neural circuits react to a stimulus. And people with schizophrenia have abnormal EEG signatures, profiles, and if you look in people with the diagnosis, you can see those. And if you start measuring those same outcome measures, these EEG measures, what you'll find is that if you're measuring that in the prodromal population, and you then get that measure, this EEG measure, there's one called a mismatch negativity. I could go into more detail, but if you just call it, there's an EEG measure, highly quantifiable, there's no opinions involved, you just measure it and it gives a number. So if you look at that measure, and then you look at the people who are prodromal, many of whom will not go on to have schizophrenia, but a high proportion will, higher than normal, that change in EEG was present years, maybe 3 years before that declaration of which ones had it and which one didn't.
Let me ask you to assume a fact. You have a person, stick with Joey, who's been diagnosed with schizophrenia, and his parents tell you, in high school, he had a really outgoing personality. He was the big personality, liked to be in front of people. And then we noticed he started to become quiet and reserved. In retrospect, could that have marked the beginning of prodromal schizophrenia, that change from being outgoing, big personality, to being quiet and reserved?
Direction, leading, and program overall.
So the challenge is, maybe it could, but there's a million other things that could be. And in fact, the earliest abnormalities in most people with schizophrenia are anxiety and depression. Right? So you imagine someone's a little bit anxious in high school. Well, there's a lot of reasons to be anxious in high school. That's not enough to say, oh my goodness, Joey's going to have schizophrenia. Then Joey becomes a little more isolated, and you go, well, he's growing up. He's being more selective with his friends. And then Joey, was a really good football player. Maybe he was on the varsity in high school, but he decides not to play in college. He's just growing up. Right? Just growing up and deciding to focus. And then, and you can see this progresses, and then someday you realize Joey's not talking to anybody. Joey's not going to class. Something really profound happened, and you track back to, remember how in high school he was a really, really different person? But none of those things in and of themselves locked you into knowing what was going to happen to Joey.
So, sir, how does a psychiatrist diagnose someone as suffering from schizophrenia? What are the criteria?
So we use the positive and negative symptoms. Right? So you have to have a set of those, enough of those. Then there's the chronicity. It has to be 6 months in duration. You're doing this by history and by observation. You're talking to them. You get to know them over time if you're able to do that, or you're getting history, reading notes, talking to other people about the past 6 months. And then there's function. So the person has to not be able to meet their anticipated role function. That could mean they're not able to work, they're not able to go to school, or they're not able to participate in care of the family in the way that they should be able to do. And we have these because of subtle changes in diagnosis. Someone can have something called delusional disorder, where you've got the delusions, but you're able to still go to work. But for schizophrenia, it's hallucinations, delusions, disorganization, and negative symptoms, some combination, coupled with, this has lasted 6 months, coupled with, and this person is not functioning in society the way that there's disability here. They're not functioning. And we have not identified a better cause. Right? They had a stroke, they have a tumor, there's massive inflammation in their brain that's causing these things. They're on a medicine that does this. Right? You rule all of that out, and if it persists in the absence of, there's no tumor, there's no inflammation, there's no stroke, there's no exacerbating medication, and it's lasted, then we use something called, again, the diagnostic statistical model manual in psychiatry, and that's because it means that if all those things have happened, they've lasted that long, and this is the outcome, statistically, the probability that this is something other than schizophrenia is very, very small. We can call it.
Is that the DSM-5?
Yes. And the 5 just means that over the years it's been refined and refined and refined.
How is schizophrenia treated?
Antipsychotic medications, which sounds like I'm just saying medicines that treat psychosis. So there's a class of medications that can dramatically attenuate the positive symptoms and help people not experience hallucinations, delusions, disorganization. They have limited, if any, effect on the negative symptoms, unfortunately. And they have limited, if any, effect on the cognitive domain, which means that you can restore some function, but usually not going all the way back to what Johnny was supposed to be, or Joey was supposed to be. Those medicines, by and large, block dopamine type 2 receptors. You could find people in my field who would argue that it's not just dopamine type 2 receptors, it might also be something called serotonin type 2 receptors. Lately there's been a kind of movement to add an acetylcholine receptor, but if you look back since 1952, I would argue that it's dopamine type 2 receptors for all intents and purposes.
And just very basically, can you treat schizophrenia with oral medication taken daily?
Yes.
Is there another treatment for certain people who receive an injection?
So there's injections that last 1 month, 2 months, 3 months, or 6 months on the market right now from different companies.
And what is the benefit of an injection as opposed to daily medication?
So again, there's some, this is my opinion, and I think, so I'll do my opinion, then I'll do data. So the data part is people do better, right? If you just say, well, I don't need to know why, there's many analyses, what are called meta-analyses, where people go across multiple studies, put them all into the same framework, and then ask the question, across these 50 studies, what's the outcome, right? And those data show that the same medicine, whether it's given by pill or shot, people just do better on a shot. They're hospitalized less, they have less symptoms, they have less distress. Shots work better. Then, if you ask me my opinion, it's because it's really hard to take medicine every day. Not to mention, you get steady state. You don't have fluctuations at the receptor where things are changing all the time. It's a stable system because the injections keep steady state for months at a time.
And so we're going to take a break in a couple minutes for my last question. Are we at 11 or 10:45?
No, 10:45. I'm ready.
Okay. So we just got a couple minutes. Sir, is antipsychotic medication a cure for schizophrenia, or is it a treatment for symptoms?
It's just a treatment for symptoms. Person stops taking medicine and they go right back to the way they were every time.
Is that a good time to break?
Yeah, that's fine. Okay, great. Dr. Siegel, thank you for your testimony. We have more questions for you. This is our mid-morning break. It's 15 minutes, and I'll see you in 15 minutes.
Thank you.
Thank you. Excuse. Why don't you walk out for the jury? To the jury, thank you. Mid-morning break, and I'll see you in the other.
Spend.
Okay, back on the record, we've got Dr. Siegel. He's been called by the defense. Attorney Hutchinson's on direct. Go ahead.
Dr. Siegel, in the most basic terms, when we say a disease is progressive, what does that mean?
That it gets worse over time.
If left untreated, is schizophrenia a progressive disease?
Yes.
How so?
The longer people spend in that psychotic state, that ill state, the worse their eventual outcome will be. The earlier one intervenes, and the more consistently that individual stays on treatment, the better they can do over time. There's evidence for that just from those kinds of data, earlier intervention, better outcome. But also, as I mentioned earlier, when people cease medication, they relapse. And when they relapse, it is often the case that they now have established a new, lower level of function than they would have had before they stopped. So if you, again, think of a kind of graph where function is going like this, right? This high function, low function, and this is time, you see the life course is the person's doing well, they get schizophrenia, it begins to decline, and they go down. They go on treatment and they climb back. They stop treatment, they go down. They climb back. They stop treatment. And so you end up with a decreasing course over time that is dictated by the duration of treatment and the frequency with which people stop treatment.
You mentioned that antipsychotic medication is less effective at treating negative symptoms. If people are stabilized on medication for several years, can they still have residual negative symptoms?
Yes, there are residual symptoms for most people. And you can think of negative symptoms as primary negative symptoms, meaning the ones that are part of the disease. There can also be what we think of as secondary negative symptoms. And so, for example, if you have persecutory ideas, right, delusions, you're paranoid and you think everybody's trying to kill you, you're less likely to socialize, to go out, and to work. If the medicines are effective for that delusion, you may have an increase in your ability to socialize, go out, and work, because that was a secondary negative symptom due to your fear. So it's hard to sometimes distinguish those, but you can see some improvement, but that primary negative symptoms seem to be less responsive to medicines than the positive symptoms.
Sir, is it common for some people with schizophrenia to not recognize or acknowledge that they are sick?
That is common. Indeed, there's a term that's been coined by a gentleman at Columbia called anosognosia. He took it from neurology. It's a fancy term of saying not recognizing, not having insight, not recognizing that you have an illness. I think many people would argue that although it's not part of the diagnostic criteria, it is actually the most common aspect of schizophrenia. One way that one of my mentors, someone I think is probably one of the best schizophrenia experts in the country, once described it to me as he said, if a patient comes in and says, "Hey doc, something's wrong, I'm hearing voices, I've got these weird things," he says, my baseline is that person doesn't have schizophrenia, right? I'm looking for something else. If someone comes in and says there's nothing wrong with me, there really are people in the ceiling, that lack of insight and anosognosia, the inability to recognize that you have a disease, is more pathognomonic for schizophrenia.
So is it common for people who you can tell clearly are exhibiting positive and negative symptoms of schizophrenia to deny that they have any mental health symptoms?
It is common. That is the norm.
Sir, how common is schizophrenia among the population? What is the prevalence of schizophrenia?
In general terms, if you read lay press, the people say it's about 1%. If you get into the data, it's actually a 0.5% to about 0.7%. So think, somewhere between 0.5% and 1% of the world population.
Have you used the number 5 in every 1,000 people? Is that...
That would be a 0.5%, right? One per 100 is 1%, so it'd be 10 per 1,000, 5 per 1,000 is 0.5%.
It's somewhere in that range?
Yes.
Sir, what do we know about the cause of schizophrenia?
So we don't really have causes, right? We can't identify in any one person why this person has it. We can look at factors that contribute. So about half of the risk, half of the variance, meaning whether you have it or not, is hereditary. So it's genetic. It is a strongly genetic disease, but there's no one gene that causes it. And again, there have been countless studies, I would say probably $1 billion or more, invested in understanding the genetic architecture of schizophrenia. And there are hundreds of genes implicated, but in total it's really your constellation of genes. Your genome, your hereditary background, imparts half of the risk. The other half of the risk is a combination of environmental factors, exposures, things that happen to your parents, and unknowns.
Let's talk about the hereditary. When you're diagnosing someone with schizophrenia, do you often ask about family history?
Always.
Is the risk impacted by how close of a relative it is? For example, is it a mother, father, grandfather, uncle? Can you explain?
So genetic risk for schizophrenia dilutes with genetic distance. So these are again, numbers that have stood the test of time over countless studies. So if you share 100% of your genetic material, your DNA, with a person with schizophrenia, meaning both of your parents have it, right? You got all your DNA from either your mother or your father, right? That's how you got it. They both have schizophrenia. Now you actually have a 50% chance of having the disease, not a 1% chance or a 0.5%. Right? You have a 50% chance of getting it. If you have a monozygotic twin, meaning there was one egg, right, one sperm, one egg, it's split, you get two individuals, so they have the same exact genome. If one of them gets it, there's a 50% chance the other one will. If, on the other hand, so that's 100%. If you only share 50% of your genetic material, so now it's one parent, right? Now you have only a 10% chance. So you have a sibling, again, you share 50% of your genetic material, a sibling, but not a monozygotic twin. Now, if they get it, you have a 10-fold increase. You have an aunt or uncle, it's 4%. You have a grandparent, it's 4%, like that.
So you mentioned aunt and uncle. So if a person has an aunt, the sister of a parent who suffers from schizophrenia, would that be a risk factor for that person developing the disease?
Yeah, so if you have a sibling with schizophrenia, your children have roughly 3 to 4 times the normal risk for schizophrenia as the general population.
Now, sir, there are other serious mental illnesses other than schizophrenia, correct?
Yes.
Okay. Has there been any studies as to whether having a parent with a different serious mental illness, such as bipolar disorder, would be a risk factor for schizophrenia?
Yes.
Can you explain?
So, I would characterize it as the more it looks like schizophrenia, the stronger that association. So bipolar disorder, the one you mentioned, is a fluctuating state of mood, including mania, the highs, where people can become, in a sense, psychotic during that episode. If you have a parent with bipolar disorder, now instead of a 10-fold increase, it's like a 3-fold increase. But if you have a parent with severe depression, it's like a 2%. It's like a 2-fold increase. So severe mental illness in the family increases risk. The more severe, the worse. And the more it either is or is like schizophrenia, the worse.
And oftentimes, when you're asking a patient about family history, are the times they don't know their family history.
Also, the norm. Yes, common. Most people don't, and there's a reason for that, right? Most people don't talk about this stuff. So if I asked you, have any of your aunts or uncles ever had a psychotic episode, it is almost assured that you do not know.
Sir, what are some of the environment, we talked about the genetic risk factors, what are some of the environmental risk factors?
So there's a host of them. All of them revolve around stressing, in a broad sense, stressing either the mother or the mother, and by extension the fetus, or a young adult. And these include children born during war, not war somewhere else, war where you live. There's an increase in that cohort of kids born to women who were pregnant during war in their country. There's an increased incidence of schizophrenia. The death of if the father dies either during the pregnancy or even in the first few years of life, there's an increased risk of schizophrenia. Exposure to influenza or toxoplasma, so exposures to infections in the mother increase the risk of schizophrenia. These things impart risk in the order of 2 to 3-fold. So it's sort of like the risk of your aunt having it is about the same risk as your mother getting influenza during pregnancy or having severe obstetric complications.
And when you're using the term fold, that means, what does fold mean? when you say fold increase?
Times. So it's 0.5% would go twofold, would go to 1%. Fourfold would be 4 times 0.5, so that would be 2% of the population.
Well, you mentioned some of the risk factors. I'm just going to go through some. Can famine or malnutrition during pregnancy or early childhood be a risk factor?
Yes, similar in magnitude to severe infections, wars, etc.
What about severe stress during early childhood?
And again, yes, so that's why I use that. It's war, famine, these are all, so famine adds a malnutrition component to stress, but anything that impacts the stress environment of either the mother, and hence the fetus, or the young child can increase the likelihood that that individual will go on to have schizophrenia. There are some other ones: urban living, immigration status, refugee status as an immigrant, even higher than immigrant status. So a refugee immigrant living in a city to a mother who had infection has multiple risk factors that would all be cumulative and increase the probability that that person would go on to have schizophrenia.
You said, urban environment. What do you mean by that?
Living in cities carries greater risk than living in rural settings. And you can imagine maybe that's because urban settings are more stressful. Maybe it's because there's greater exposure to infections because you're living in close quarters. But pragmatically, it just is, right? If you're born in an urban setting, a city, a densely packed city, you're more likely to develop it than if you're born in a rural setting.
I want to go back to one you mentioned about death of the father, and before the age of 5. Is it specific to the father dying, or could abandonment by a father before the age of 5, could that also be a risk factor, if you know?
So I haven't seen that study per se, but I bring it back under the same rubric of stress. Anything that's going to add significant stress overall to the mother and the environment that the child is in seems to have a small but quantifiable risk. All of these things in constellation, each one individually, is, it increases the risk 2 or 3 times. There's no smoking gun, there's no one thing, it's just the constellation of all of these causes your overall risk profile.
Let's go on to some other risk factors. Can substance use be a risk factor?
Yes.
Okay. Does that include alcohol?
Yes.
Sedatives?
Yes.
Amphetamines?
Yes.
And cannabis?
Yes.
Okay. Are these, explain how that can be a risk factor, the use of substances.
So mechanistically, may I clarify?
Sure, absolutely.
So, not talking about what they do per se and how that changes your biology, but just how do we know that?
Yeah.
So you can look at people who've developed schizophrenia and then retrospectively, looking back, ask, what have you done? Right? Where did you live? What happened to you? And what have you done? And it turns out that if you've used amphetamines, hallucinogens, anxiolytics, so medicines for benzodiazepines, things like Valium, or cannabis, you're more likely to have developed schizophrenia than if you hadn't. So it's generally a retrospective thing, and it might be something like we look at everyone who has schizophrenia in a big population, say that 1,000 people, and we would say that of the people who've used cannabis or hallucinogens or alcohol prior to diagnosis, it can include the 3 years where they were already getting sick, that prodrome, we would say 7 out of 1,000 of those people went on to have schizophrenia. But if you look at the ones who never used anything, only 5 out of 1,000. So that's the order of magnitude here. With substance use of any of those kinds, it's going to be 6 or 7 people out of 1,000. But without any of them, it's 5.
Sir, are any of these risk factors by themselves causal?
Not that anyone knows of. There's no evidence that you could link any gene, any infection, any drug to a specific individual. And the way I would think about that is, let's look at drug exposures in general. Say it brings the incidence, the rate at which people get sick from 5 in 1,000 to 7 in 1,000. Well, out of the 7, 5 of them would have got it anyway. And so you have no way of knowing. Not to mention, drug use among that age group, right, is in the 20-30%. And so again, 0.7% went on to have schizophrenia, whereas maybe 30% were exposed to those drugs. You can see that 90-something percent, 98, 99% of people exposed to drugs don't go on to get schizophrenia. So it's very hard, if not impossible, to do causality.
Sir, in your opinion, is it medically or scientifically possible to ascribe a single cause to a person's later development of schizophrenia?
It is not.
Sir, what is a substance use disorder?
Substance-induced...
Substance use.
Sorry.
Start with that.
Substance use disorder is just an operational definition for when your substance use becomes so bad, so pervasive in extent and impact that it's impairing your function and meets this criteria for a disease, meaning it's causing impairment and is amenable to treatment.
So if a person is an alcoholic, would that be a substance use disorder?
Yes. It's alcohol use disorder.
And can someone have a substance use disorder based on cannabis?
Yes, there is cannabis use disorder.
Is there a use disorder for basically every drug?
Yes, and again, it's extent and impact.
Sir, what is a co-occurring, I hope I'm using the right word, what is a co-occurring medical condition? What does that mean?
So there's something called dual diagnosis or co-occurring, where two things can be present. You can have asthma and cancer at the same time. You can have major depression and alcohol use disorder at the same time.
Sir, in your experience, how common is it for people who have schizophrenia to also have a substance use disorder?
So substance use in general and substance use disorder is elevated among people with schizophrenia. It's not a number I have in my head for each individual one. It's something I would look up and just find the data, but it's elevated. So among people with schizophrenia, substance use is higher than it is in general population.
And does that include cannabis use?
Yes.
Sir, is there any overlap between the genetic risk for schizophrenia and the genetic risk for cannabis use?
There is, and I can explain how people make statements like that if that is of interest.
Yes.
So the way these genetic studies are done is you can look across someone's genome and quantify the prevalence of specific amino acid sequences, or not certain base pair sequences. So the genetic code, it may be in a gene that we know, the hair color. It can also be in a region of the DNA that we don't actually know what it does. But you have these markers. And you can take a population, like people with schizophrenia or people with cannabis use disorder, and look at how frequent these genetic markers are, these genes or these regions of DNA are in the people who have the disorder and the people who don't. And then statistically, you can ask the question, are these genes or genetic regions disproportionately present in people with the disorder relative to people without the disorder? And then you apply a statistical model that tells you the likelihood that that's random and come to a conclusion as to whether they are related or not. And if you do that, you find there's a high degree of overlap between the regions of DNA that are identified as more prevalent in people with schizophrenia than not, and those same genetic regions that are more prevalent in people who abuse cannabis and not.
Sir, what is substance-induced psychosis?
So psychosis is the symptom as opposed to the diagnosis for hallucinations and delusions and disorganization. That individual is psychotic, right? And a substance-induced psychosis means that to the, you believe, the person making the diagnosis believes that the psychosis is resulting from the exposure to that substance.
What substances can potentially cause psychosis?
Amphetamines, so speed, or medicines like speed, treatments for Parkinson's disease, things that increase dopamine. So there's a bunch of medicines that cause psychosis. Hallucinogens, so mushrooms, LSD, those can cause, false sensory, they're called hallucinogens because you hallucinate, and cannabis can as well.
Can alcohol also cause?
There can be an alcoholic hallucinosis or hallucination, so in extreme cases, alcohol and or alcohol withdrawal in particular, right, leads to hallucinations.
What is the difference between being under the influence of a substance and suffering induced psychosis as a result of substance?
So it's the expression, it's having that symptom, that experience or not, while intoxicated. Most people can relate to the idea that, you've had, you have one beer and you're a little bit intoxicated, right? To a level. You have 4, you're very intoxicated. The vast majority of people will never hallucinate as part of that. So they have intoxication. They don't have a intoxication-induced psychosis.
Psychiatrist, how do you distinguish between someone who is suffering from schizophrenia as opposed to, let's say, cannabis-induced psychosis?
You have to remove one of them, right? You have to remove the cannabis, or you have to look at the extent. So, as an example, if someone has a minimal dose of cannabis, one mild gummy once a month, and they're psychotic all the time, you're not going to link those two things. The relationship between the extent of exposure and the degree of symptom are so disparate that you couldn't link those. But if someone is using a lot of cannabis every day and they're psychotic, you cannot disambiguate these in that moment. You need to stop the cannabis and then wait and watch. So in cannabis-induced psychosis, which can happen, and it's rare, but it happens, and if that happens at high dose with a lot of exposure, again, rare, but it happens, the vast majority of those will go away in 24 to 48 hours. An overwhelming majority of those will go away in a week. And if you get to a month, so you've gone 30 days without exposure, according to the DSM-5, right, the official way that diagnoses are made, you are not allowed to ascribe the cause of that psychosis, right, because it's still here, but the person hasn't been exposed to the agent, in this case cannabis, for 30 days. It is no longer statistically likely, it is no longer plausible that the thing that stopped 30 days ago is still causing this.
So, sir, if you would assume that a person is still suffering symptoms of psychosis 3 years after the last use of cannabis, under the DSM-5, could you ascribe that to the cannabis?
No.
Overruled.
I think the objection.
Overruled. Thank you. Sorry.
Again, the official rule is a month. So a year, 3 years, that's way out of bounds.
And you said the majority resolves within,
24 to 48 hours.
so the month,
Certainly a week. Sorry.
but the month is basically the cutoff?
Yes. Again, the way psychiatry works is we look at the probability that an outcome is going to change or prognosis is that we understand the prognosis. So applying that kind of criteria, what it's telling you is that if you make it a month out and the person's still psychotic, you've now moved into there's no probability that was the cause anymore.
Sir, we've spoken about cannabis-induced psychosis. Can cessation of cannabis or withdrawal, can that lead to psychosis?
Yes.
But would that 30-day rule still apply to that as well?
And that's where those things are completely consistent, right? Because when the person's on it, you have the declining level, you're looking for the decay, right? The decreasing impact. You can also have, if the person's been on it for a long time and they've used a lot, their brain's adapted to it, they can go through a withdrawal where now as part of that withdrawal process, they can have symptoms. But all of that's the difference between 24 to 48 hours and say a week. By a month, all of that has unwound, and you're left with a brain that is no longer influenced by the substance being present or influenced by the withdrawal of that substance. And so now you're looking at the brain in its sort of native state, and that is kind of what you see is what you get. And the idea is you can't put that back to the thing that's over.
Sir, what is meant if a journal article uses the term converted or transitioned from one diagnosis to schizophrenia? What does that mean?
It means that one happened and then subsequently the other happened, and you're saying there was a transition or a conversion. You used this term and then later you use this term. It does not infer that they are related or even that there was a mistake. It just means kind of like, I used to think this, now I think this.
Okay. So, for example, if someone were to come in and be initially diagnosed with cannabis-induced psychosis, and later that diagnosis is changed to schizophrenia, and someone uses the term converted, what does that mean?
It means that at the time they were first seen, there was evidence to believe that what they saw was due to cannabis. But at the second time point, there is no longer evidence to ascribe cannabis as the cause, and you've corrected the diagnosis to schizophrenia.
Okay, so does the term converted or transition, does that mean caused?
No. May I use a different analogy? So you can imagine someone's hasn't yet been diagnosed with asthma. They're developing it, right? They may have it. They're going to have it soon, but you haven't made the diagnosis. So in that person, they're exposed to dust or pollen, and they have a severe reaction. And you start off with a sort of hyperreactivity to pollen, hyperreactivity to dust. Then you realize later with diagnostic testing, and they have asthma. Well, it's not that because they were exposed to dust, now they have asthma. You used to think it was just the dust. Now you realize it's the asthma.
Sir, have you ever had occasion where you have patients or family members who wish to decrease or stop their medication during periods of decreased symptoms to see if they, quote, really had schizophrenia or really have schizophrenia?
Yes.
What are the risks of doing that, sir?
So I call this a high-risk procedure. I mean, I try to really frame this for patients and their families that this is a pretty serious thing that we're going to do, and there's a lot of risk associated. It means that, so if they have schizophrenia, right, if the diagnosis was correct, there is basically a 100% chance they're going to relapse. And when they do, I cannot guarantee, and not in a schmarmy kind of like cover my whatever, I really cannot guarantee that I'm going to get them back to the place they are today. Right? That's that progressive decrease that I spoke about earlier. It takes more medicine, it takes longer, and you don't get back to the same place. Being psychotic seems to be a toxic state. So what I say is we can decrease the medicine. Now, when we decrease the medicine, it takes about 3 months for medicine's effects to be fully realized. It could take 2 to 3 months to see the unraveling. And so the way I do this high-risk procedure is to say, one, I really need other people to know, because you as the patient, because of that anosognosia, you may be the last person to realize that you're unraveling. So we need other people to know. You know, it has to be your roommates, your family, someone's got to be my eyes on you. We're going to decrease it really slowly because it may take weeks to months for you to begin to unravel. And if we wait, if we do it all too fast, sort of horse could be out of the barn. And then we're going to do this over maybe the course of 6 months or a year. Then we're going to wait 6 months to find out what happened. And at the end of that, I also can't guarantee you won't end up being the guy on the highway encrusted in feces and end up dying in some other terrible way. So it's an incredibly risky endeavor that I think people have to understand is could be life-altering.
Sir, for a person with schizophrenia, can substance use, including cannabis use, impact their psychosis and behavior?
Absolutely.
How so?
So think of, you got kind of a low burn going, and then you pour some oil on it. You put some gasoline on it. So things that make you more psychotic in general make people who are already psychotic or sub-threshold, they're close to psychosis, move up. You can really think of psychosis. I use this way of explaining things a lot, the sort of graph, right? If we had a continuum of how psychotic are you, right? Most people, most of the time, not very psychotic, right at the bottom. But you use some amphetamines, you'd really tie one on with a drink, or you use high-dose cannabis, and you become a little more psychotic. Well, if you started a little bit psychotic, then you might move across threshold where people notice. Right? So,
and is that true of all substances? That alcohol, cocaine,
yes.
amphetamine?
And I really implore my patients. So I have a schizophrenia practice, and I really implore them to stay away from all substances because it just makes them function worse, and they're already struggling.
Sir, in your opinion, based on your review of research and data, does cannabis use cause schizophrenia?
No.
Why not?
Well, again, as I mentioned, there's multiple factors. The vast majority of people who use cannabis, like 99.3% of people who use cannabis, will never develop schizophrenia or psychosis. Among people who have psychosis, it's just one of many, many risk factors. And not to mention, there's all this sort of conflating of timing. And what I mean by that is, let's look at someone in the prodrome, right? So again, I mentioned before you get the diagnosis, on average, it's 3 years before you come to attention, but you've had a loss of function. So during that time, well, one, you have shared genetic risk. We covered that. 2, you've got social isolation beginning to form. You may have poor function beginning to form. You may have poor judgment beginning to form. So is it that you used and then that exacerbated your psychosis? Or is it that while you were becoming psychosis, you were disengaged, not around other people, not going to school, had poor judgment, and used? We cannot distinguish those two possibilities.
Sir, in the last 20 years or so, has there been an increase in the availability of cannabis?
Massive.
Has there been an increase in the availability of high THC cannabis?
Like massive.
Okay. Has there been any change in the rates of schizophrenia?
No.
What does that tell you?
Objection, we overruled.
That despite the massive increase in the availability, prevalence, and strength of cannabis, that's had no impact on the proportion of society that goes on to have schizophrenia. And so for me, the way I interpret this whole thing is that exposure to cannabis is identifying schizophrenia more frequently or earlier. So we see cannabis-induced psychosis and then people having schizophrenia. In my mind, this is cannabis revealing the sort of impending development of schizophrenia. It's not causing it, because if it was causing it, then all of this extra cannabis in society, high dose and regular, would be leading to more schizophrenia, and it's just not.
I have no further questions. Thank you, sir.
Okay, thank you, Mr. Hutchinson. That was direct by the defense. And Mr. Keon, then cross by the people.
Thank you, ma'am. Morning, sir.
Good morning.
We met earlier, right?
Yes.
As I said earlier, my questions to you are not going to be designed to be any tricks. We're just going to get more information, and I can get some better clarification of your responses and everything. And so, if there's any questions I give you that you don't understand or you need more clarification, please let me know.
Okay, thank you.
And if you wish to elaborate, feel free to let me know as well, okay?
Yes.
So, bear with me here. So just to start off, your opinions, everything you're talking about, that's from an academic level today. Is that true?
Yes.
Okay. This is not meant to be any sort of diagnosis, any sort of an attribution to any one particular person.
Correct.
Okay. And all of the information that you are providing, that is based on your personal academic experience, clinical experience, as well as things you've read from others.
Yes.
And part of academia is the ability to disagree. Would you agree with that?
Yes.
That's actually how academics and science grow, right?
Yes.
So, a couple things, and I'm going to try and do my best to follow through in the order that was done with direct examination. Early on in the direct examination, you talked about you reviewed research on adolescent drug abuse. Do you recall that?
Yes.
One of the questions I had is the research you reviewed, what type of drugs were in that research? Was it comprehensively all drugs? Was it specific types of drugs?
Largely do you mean in preparation for today or my whole career?
I believe the question was asked that you had done research on adolescent drug use.
Yeah.
Did you do it specifically for today?
No, the research, thank you for the clarification. No, my laboratory has looked at a variety of substances and their risk for how they affect the brain.
Okay, and what substances were those?
So we have studied nicotine, we have studied cannabinoids, we have studied, trying to think back of all the studies, we've looked at amphetamines. I could go get my CV, but that's most of them.
No, I just wanted to get a general idea because would you agree that when we say drug use or drug abuse, that's a pretty broad term?
Yes.
Okay. And so that's why I wanted to clarify. So the ones you could remember, nicotine, cannabinoids. Cannabinoids is basically cannabis?
Yes.
Okay. Why is there a difference?
So there's a few others. It's cannabis. It's also cannabidiol. It's also looking at the intracellular, inside the cell, mediators of what happens when cannabis or THC, tetrahydrocannabinoid, or cannabidiol impact the cell or the brain.
I see. So that type of, so cannabinoids is just a broad term?
Yes.
And in those studies or research, when you reviewed cannabinoids, is that a broad range of meaning different types of cannabis, or is it a specific type?
So in my research is much more narrow than my reading and understanding of the literature. I would say the reading and understanding of the literature is broad. The work done in my particular lab, much more narrow.
The work done in your lab, what aspect was more narrow?
Well, so for nicotine and I'll just go through to the best of my memory. For nicotine,
and I'll apologize just because of each time. If we can focus on cannabinoids, that.
So what I've studied in my lab is largely cannabidiol, which is a variant of cannabis that comes from the same plants, and looking at how that impacts the brain.
Gotcha. And I apologize for interrupting.
No, that was helpful. Thank you.
I'd love to learn about the other aspects, but we are focused on time. With respect to your focus, did you also look at, for example, butane honey oil?
No.
And you know what that is, right? The more concentrated.
So I'm sorry, I don't know that term, but if it's a concentrated form of cannabis that's used, then I'll go with that.
My apologies. When I say butane honey oil, it may be just semantics on another term scientifically, but a more concentrated version of what will be under the cannabis umbrella.
So I've not studied that myself. No.
What about, have you heard of something called keef?
I don't know that.
Or gummies?
Yes.
How about hash?
Yes.
And what's the difference between hash and cannabis?
So my impression is that hashish or hash is a concentrated form of THC that is in an oil and extracted and goes into little pucks, so to speak, that people smoke. So it's like a concentrated version of pot.
Are you familiar with the potency level between that and the standard flower?
I don't know those numbers off the top of my head.
Do you believe that the potency with cannabis can affect adolescent brains?
Yes, so potency is the amount of the substance, the psychoactive substance has increasing, the more potent, the more impact it has on a brain.
So, for example, if an adolescent is consuming just a very mild, I think you coined it earlier as an example, one every month of a mild, you're not going to associate that with schizophrenia, right? You said that earlier.
To be clear, I said you wouldn't associate that with cannabis-induced psychosis.
Thank you for the correction. You would not associate because of how infrequent that is, true?
Yes.
Would the same be true with potency as well, or is there a different relationship with potency?
So it'd be kind of a potency times frequency equation, right? So if someone was using a regular dose of cannabis every day, it would be hard to disambiguate that from a cause and effect for what they're experiencing now.
What about multiple times a day?
Again, even if it was a mild dose, but they were smoking or taking it in, vaping, eating multiple times a day, during that period, it would be impossible to say that's not relevant.
Right. Would you say, as far as adolescent brains, what would you consider a mild user, a moderate user, and a heavy user for cannabis use? What's your distinguishing lines?
So I would think, every day or nearly every day would be heavy, weekly or once or twice a week, I would put into the mild or moderate, and mild would be a few times a month.
Okay. And so you said heavy is every day or nearly every day. Is there a separate designation for, let's say, a heavy user, but their use is not a minimally potent cannabis, but a strong potent cannabis? Is there a separate distinguishing, or is it all just lumped under just heavy use?
So I think it's a continuum, rather than a discrete, heavy, so daily or nearly daily use of these very concentrated versions that are now available would be worse than daily or nearly daily use of a milder form. And so again, it would be a dose times frequency assessment of total exposure, which would be dose times frequency, that one would need to incorporate. And at a certain point, it does become a judgment call of, is this enough to explain what's in front of us?
I guess going back to your research, when you say adolescent brains, was there a particular age range you were researching, if you recall?
So again, in the context of work done in my group and cannabidiol, it's young. Well, there's two parts. Our lab studies mice and brain function. I also worked on projects and with collaborators on exposure in humans, and there it was tended to be in children and young adolescents in a disease state.
What would be the age range between children versus adolescents?
Below the age of 12, or so, we would call 11 or 12, we would call children. Above 11 to 18, we would call adolescents.
Okay. And so, let's say somebody who fits the mold for an adolescent, you said 11 or 12 to 18, and they are consuming what you call the heavy use, so dose times frequency, daily. To what degree, based on your understanding, would that affect the adolescent brain?
So I would expect it to have the same sorts of acute effects, right, that you would have in anyone. Meaning that if it's an intoxication dose, whether that's just intoxication without psychosis or bleeding into psychosis, I would not expect them to be different, so to speak. Now, it is a developing brain, and so one has to entertain the possibility that it could impact developmental trajectories, although how that would happen and what would happen is less clear.
Is it fair to say that somebody who does not regularly, who's not a heavy user, or even doesn't smoke cannabis, and someone who is, the normal day-to-day behavior will be a little different?
I believe that you would expect to see overt manifestations, observable behavioral changes in someone who's got heavy use versus someone who doesn't use. Now, they may get very good at hiding it, right? But as a group, you would expect to see changes, yes.
Is that what's considered masking, so to speak? You're masking your...
That would be a good term for it, yeah.
Okay. And I don't know if your research delved into this, but how does drug use play a role in memory?
So drug use can impact memory. So drug use or exposure to medicines, right? So exposure to chemicals that impact how your brain works. And the most common example that we learn about is there can be state-dependent memory. So if you learn something while you're high or drunk, then you have difficulty recalling it when you're not.
Okay. And what was that again?
I'm not sure I'm using an exact term that but this sort of state-dependent learning.
Is that what we say is the equivalent of, I don't know, those movies where and I'm shifting to alcohol, but you say someone who's really drunk, they go to somewhere, they get something, they wake up next morning, they don't remember getting what they got. Is that what you're talking about?
Depending on what that thing was, it could be the alcohol, it could be the other thing. But yes, I think that's probably not outside of many people's experience to say that if you had a lot to drink, you might not remember everything that happened the day before, the night before. And that is a good example of it's either impacting your capacity to lay down memories, or it's creating a context in which that memory retrieval is dependent on the state with alcohol.
And so, with respect to drug use and memory, if someone does not remember during their, for lack of a better word, I'll call it their intoxicated state, is that something that indicates an ability to remember later, or what's the ability to remember something later versus
outside scope?
Memory, vocal. Go ahead. You can finish your question.
Sure. So, as you talked about, someone who's in an intoxicated state before drug use, they may not remember versus when they're sober. Can that once they're sober, develop a way to remember, or is that memory locked away?
So,
Go ahead.
may I restate what I think you're asking me and make sure I understand?
Yeah.
So, I think you're asking me if somebody can't remember something that happened while they were intoxicated, is it the case that the memory simply wasn't formed and therefore cannot be retrieved? Or is it that the memory was formed but they're unable to access it because of that difference, and there might be a way to retrieve it?
Thank you. Yes.
So that in general is the distinction between recall and recognition memory. There's things with or without alcohol, right? This is a general, and so the alcohol doesn't take this away or create it, right? And in fact, in schizophrenia, this is my context, there's a distinction between recall and recognition. The way we test that, so to make it really clear, is we expose people to a list and we say, here's 8 words. Then you ask them to recall those 8 words, and they do very poorly. Then you show them a list of 20 words and you say, pick out the 8. Now, if they've never laid down the memory, showing them the 20 will have no impact. But if they've laid down the memory and the fundamental problem is retrieval, it's finding that memory and bringing it out, recalling it, then they'll do better on recognition than recall. And that's what we find in schizophrenia. There seems to be a problem retrieving memories that were in fact encoded, but you can't access them without a hint.
Got it.
Without a hint?
A hint, H-I-N-T. Thanks.
And so individuals who may be unable to recall a memory, you're not saying that they're unable to function, are you?
It depends on how bad the problem is. But you can have problems with recall memory that don't impair your day-to-day activities, but it's going to be an extent issue, right? If you can't remember the majority of things that are happening day to day, there's not a lot you're going to be able to do. But if you have the occasional lapse that comes back with a prompt or a hint, then you might be able to cover that and do okay. Why don't I stop?
So, for example, somebody who may have accidentally broken a window and has no memory of it, that you're not saying that person who may not be able to remember for whether it's whatever it be, they're not able to still go to work, go to class, go to a wedding, and so forth. They can still function.
Again, I'm going to go with extent, but yeah, so a single episode where you can't recall a specific event, if it's not pertinent to the thing you're being asked to do now, wouldn't necessarily cause an impairment. But your inability to lay any memories down and recall them likely would have more impact.
Right. That's fair. And There's also another condition that somebody who's unable to even develop, someone who can't retain short-term, long-term memories. What is that called? I forget what that's called. There's a term. There's a disorder for that, right?
Can't retain short-term and long-term memories.
And/or long-term memories.
So doesn't have a memory then.
Yeah.
I'm sorry, I feel like there probably is, but I don't know what you're thinking of. So,
have you ever seen that movie?
Wait, hold on.
Objection, outside the scope.
Yeah. Sustained. All right. Dr. Siegel, do you have more questions? Okay. All right. We're going to take a midday break. I appreciate your patience with the court. We've got more questions for you, and we're going to start back at 1:30, so it's not.
That was actually kind of funny. Is there a word for short-term memory? Or I'm sure there is, but I can't think of it right now. Actually, that's not what he said, but he's like, I'm sure there is, but I don't know which one, what you're thinking of. It's called short-term memory loss, or not being able to recollect. Doctor, what is that word for short-term? What's it called? Short-term memory loss?
On Monday morning.
Sometimes I just crack myself up. All right, let's get back to Dr. Siegel. Yeah, he's a really good witness. I really like him. He's really easy to understand. I want to hear more experts that actually treated, psychiatrists and psychologists and health social workers that actually treated Carlos. The first trial, I think there was like 5 or 6 of them. Like 3 psychiatrists, 1 psychologist, a couple social workers, court appointed. So I'm going to try and find them because we're like 4 days now, 4 days, I think, into the defense. His dad and his sister have testified for sure. I think one of his social workers testified, like when he first came in. So I definitely want to grab those. We'll definitely watch those. I want to hear more from the people that actually treated Carlos. Dr. Siegel is more just cannabis expert. He's basically the correlation. And what I'm getting is there's absolutely none. I love his numbers because the data doesn't lie. 99.3% of users never develop schizophrenia. It goes from 5 out of 1,000 to 7 out of 1,000. And the substance use in that age group, which is 18 to 25, is at least 20%. It's like 20 to 30% of kids or people of that age group are doing cannabis. So it goes from 5 out of 1,000 to 7 out of 1,000 develop schizophrenia. So there is no correlation. So that just blows up, in my opinion, that just blows up the state's theory like out of the water. So let's see what more they can pull out on cross.
Risk of developing schizophrenia if that individual has a family member with epilepsy.
Now, we spoke about earlier about bipolar disorder, and I think you described it a little bit, but can you describe what are some of the common symptoms that someone with bipolar disorder may exhibit?
Certainly. So bipolar means 2 poles, 2 directions, and it reflects changes in affective state, your mood, such that people have periods of depression or major depression interspersed with periods of what's called mania, in which case they have elevated mood. Some of the other symptoms of mania are lack of need for sleep, what people think of as a sort of influx of thought that's uncontrollable, like a racing mind, and risky behaviors. It's a period of poor judgment when people will exhibit a variety of risky behaviors and often has grandiose delusions.
Sir, in your experience, are there people who suffer from bipolar disorder who may go many years without seeking treatment or being formally diagnosed?
Yes.
I have nothing further. Thank you.
Okay, so that was supplemental direct. Mr. Mr. Keon can cross on that subject and the other subjects covered by direct. Okay, so back to cross-examination.
Good afternoon.
Good afternoon.
Hopefully you had a good lunch.
Yes, thank you.
All right. Okay. So, I know we talked about memory and some drug use in the morning session.
Can I get pull that mic?
Yes, thank you.
You can keep it there and then angle it towards you. There you go.
Yeah, all right.
Yeah, thanks.
Okay, so just going right into it, let me ask you, we talked about in the morning whether someone can still function. Another way to ask you is this. Have you heard of something called goal-directed behavior?
Yes.
What is that?
It means that you're, it's what it sounds like in the sense that you're doing things with a particular outcome in mind and acting towards that outcome.
Okay, and is that significant in the psychiatric community, in any sense?
In the sense, yes, in the sense that it's in some ways the opposite of what we described earlier this morning as disorganized behavior.
Okay. Is that significant for the evaluation or diagnosis of any potential mental illness?
So while not specific to any one illness, that would be on that same continuum when someone's evaluating whether a person has any of the symptoms of schizophrenia. Goal-directed behavior would be the opposite of disorganized behavior, and so if someone was exhibiting good goal-directed behavior, they would not meet the criteria for disorganized behavior, which was one of those positive symptoms.
What is, just for the clarity, can you give an example of what would be a goal-directed behavior?
Walking into this room, walking up to the podium, and asking someone questions consistent with their mission for that job.
You just described me.
You are exhibiting goal-directed behavior.
Got it. Touche, thank you. So just to clarify, if goal-directed behavior is something that is doing something for a particular purpose, is that fair to say?
Yes.
Would you consider going to work goal-directed behavior, for example?
It can be, yes. So if you're going to work and getting there on time and performing the duties of your job appropriately, that would be a good example of someone having the ability to have goal-directed behavior.
What about class, going to class?
Similarly, if that's one's role function and you're supposed to be doing that, you're going to class, arriving on time, and attending as you're supposed to, yes.
What about if you are going to class and you need to use a bicycle to get up there, you know how to ride a bike, you get to class, does the aspect of knowing which way to go to get to class, is that consistent with goal-directed behavior?
Yes.
What about hobbies, recreational hobbies? Is that something that could be considered goal-directed behavior?
Yes. All of these things share the principle of having a specific goal in mind, an outcome in mind, and then pursuing that by performing the appropriate action to achieve that goal.
Does making music, is that considered goal-directed behavior?
Objection, onset stroke.
Overall, you can do that. It's the opposite. We're on a symptom of schizophrenia with disorganized thoughts, so we're exploring the flip side of that one symptom. Go ahead.
So again, it could be if someone said, you know, what I want to do today is make music, and they sit down and they make music, then they're again pursuing an action that achieves their stated goal, and that would be considered goal-directed behavior.
Does the more complex an action is,
Does that play a role in any thought or evaluation?
I could see that on a continuum of the more complex the action, the more that's required to do that, and one could easily see that those would degrade in proportion to how complex something is. You could do something simple to a greater extent than something moderately difficult, which would be to a greater extent than you could do something that's very difficult if you had an impairment.
So something complex such as building a computer, that could be goal-directed behavior.
Yes?
And it's complex, right?
Yes?
What about something simple like brushing your teeth? Or
One would need to be pretty impaired to not be able to do brushing your teeth, but that would be, again, on that continuum. By the time you lost the capacity to just perform a simple habitual action like brushing your teeth, that would represent a fairly severe loss of goal-directed behavior.
what about making food?
Again, based on the complexity of it, yes, putting something in a microwave and heating it up, you would expect to retain that longer, right? Or with mild impairment, you might be able to take out something, put it in the microwave, and prepare that. You might have more difficulty following a complicated recipe. So,
Is it your opinion that people with schizophrenia are still capable of doing goal-directed behavior?
Many people with schizophrenia, much of the time, can do that. So there's a continuum of severity across people, but there's also fluctuation over time. So I might have a patient who, presently, while well treated, is pursuing a graduate degree. That same individual at a different phase might have difficulty putting clothes on.
And so, with respect to individuals living with schizophrenia, depending on whether they are still doing goal-directed behavior versus not, does that affect treatment?
It's one domain. So, for example, you always want to treat, right? If someone has a diagnosis of schizophrenia, you always want to treat because there's no credible evidence that that individual is going to be okay in the long run without treatment. The urgency with which one pursues that ultimately can force it in some circumstances has to do with the risk of not treating. So, when the lack of goal-directed behavior progresses to the inability to bathe and clothe oneself or seek shelter from harsh weather, we can intervene and force treat. But if someone simply dresses poorly but retains their safety, we offer treatment, but we can't force it. But if they have schizophrenia and they have hallucinations, delusions, negative symptoms, and they've retained the ability to perform even complex tasks, we would still treat.
Understood. And going to other symptoms here, with respect to schizophrenia, you talked about hallucinations and delusions. Those are some positive symptoms, right?
Yes.
You talked about how what was once a common delusion of a transmitter in the tooth. You said that was fairly common and you heard that.
That's what I've heard many times over the years.
Does someone's delusion or hallucination who's experiencing psychosis or schizophrenia, is that influenced by their environmental factors? How do these manifestations happen?
So there's two ways that I'd like to address that. One is the extent to which people are experiencing symptoms can be very sensitive to their environment. Sometimes a person might be sort of going along, they're in treatment, their dose is stable, and they're well, and then they have an acute exacerbation. So the first thing we do is ask, did you stop your medicine? And the second thing you ask is, what else is going on in your life? So is there a death of a parent? Was there some sort of acute event that stressed someone? And what you find is that when you take someone even stable on a certain dose and you add stress, their symptoms react. You react with treatment until that abates, and then you might be able to back down later. But the environment fuels, to some extent, the symptoms. So there's another way I could address that, which is, to what extent does the content of someone's symptoms, does it vary with an environment? And so to some extent, people incorporate content that they've heard that's possible. One might imagine that someone with schizophrenia in the Middle Ages wouldn't have thought about transmitters because transmitters weren't available. But one of the things I've been struck with is just the consistency of schizophrenia across cultures. As an example, I did part of medical school in Japan, and when speaking to patients in Japanese, the content of what they said, talking about the local military base and transmitters in their mind, was strikingly similar to the content I heard here, but contextualized to their environment.
Understood. And you mentioned Japan. I did judo there. You ever tried jiu-jitsu?
No, that's more dangerous.
But, heard the country that does it, Brazil, may be a good source. Going back to the environment, you said that someone from the Middle Ages wouldn't necessarily think of transmitters. If someone were to see passing cars or something like that, could that influence what they are perceiving as far as their delusion or hallucination?
So I think people do incorporate things in their environment. It's often difficult to understand why that element, but people's delusions generally do fit into the context. As an example, someone might say they believe someone's living in their ceiling because they hear the voices coming from the vent. So this idea of, one, they're hearing things, right? The second is that they've got a delusion that explains to some extent that. All fits a general pattern of schizophrenia, but the way that they've manifested by there's someone living in my ceiling because I hear it coming from that vent is more contextual.
Okay. What about other sensory perceptions such as auditory or visual stimuli? Does that affect the hallucination or delusion?
So I want to make sure I'm answering what you're asking.
For example, someone watching Chris Farley on Saturday Night Live, would that affect a person's hallucination or delusion?
So maybe, people incorporate things in their environment, but it's not like I could tell you that there's this one show or one phenomenon that's more often incorporated than others, or at least I've never experienced that. I think people just seem to incorporate their surroundings and fit it into their own delusional system.
Let me ask you, I'm going to shift slightly here. You talked about catatonia. Can you explain what that is?
That's a period where the person is sort of locked in. They don't move, they don't talk, they are breathing, their heart rate, their heart is still working, but they're non-responsive and rigid. They can display something called a waxy flexibility. And so when I was training, I think I mentioned when I first introduced myself, my first 5 years, I was an inpatient, not inpatient, an inpatient attending, meaning I took care of patients who were hospitalized in the schizophrenia unit. And in those days, people would talk about how in the old days, there might be a patient who was catatonic and someone would position them. And then the person just stays that way. So by the time I trained, nobody did things like that, but it spoke to that waxy flexibility where not only is the person not moving, but if you position them, they just stay like that.
And catatonia is not exclusive to schizophrenia, right?
It is not.
In fact, other conditions could be indicative, or being in a catatonic state could be a symptom of something else.
It can also occur in severe depression.
How about significant stress?
I've not heard of someone becoming catatonic just because of stress, which doesn't mean that there isn't some case out there that you may be aware of. It's just when you hear catatonia, you think major depression, schizophrenia. One doesn't normally think, ooh, I wonder what happened stressful to a person without a major underlying psychiatric illness.
So as an example, if let's say someone's car is driven off a balcony and been completely damaged, somebody could be in a catatonic state, right?
Well, they might be dazed. They might be stunned, so to speak. But that's, in my mind, very different than being in a catatonic state, which can go for days and weeks.
Could it go just for hours too?
A catatonic state could. Generally, that would resolve when you administer. There's a treatment. You can give somebody a medication that rapidly resolves catatonia, and then it generally regresses.
Have you ever seen the movie Ferris Bueller's Day Off?
Objection, outside scope, sustained.
All right, I'll move on. How do you tell if someone with schizophrenia is in a catatonic state?
It's generally by trying to communicate with them, and they don't answer back. It's one might use something like a gentle, touch, some way of trying to show that they're awake. Making sure that they're awake. And then it's really repetitive exams over time, different people across, hours to days that all indicate that it's not purposeful. It's not like the person moves when no one's looking. They're not getting up to go to the bathroom or go to eat and then go back into that state. It's this persistent, immobile, unresponsive state that doesn't resolve on its own and isn't subject to the whims of the individual.
Could someone who's under the influence of drugs be in a catatonic state?
I mean, you might appear to be in a catatonic state if you were so intoxicated that you were unresponsive, but that would be intoxication. There'd be ways that you could assess that through, a blood sample or a urine sample, and it would wear off in the time course of the drug leaving that person's system, which would be very different from a persistent catatonic state in the absence of a substance.
Understood. Have you ever heard of a term called selective mutism?
Yes.
What is that?
I have to say I have not thought about this in a very long time. If someone asked me that, I would say it sounds like the person is choosing not to speak or is situationally mute, but I don't have a deep understanding of selective mutism.
Is that a concept that is within the psychiatric community or psychiatric field?
Yes.
That specific concept, is that generally, and based on your response, is it fair to say that it's not something that comes up very much in your practice or in your academia?
It does not, and that might reflect my practice, but it's not something I've heard frequently.
Now, nevertheless, whether you've heard it frequently, that is a topic or a concept that's still prevalent in the community, right?
I've certainly heard the term. It doesn't come, so I might be an attending on an inpatient unit even in the last few years, and that might not come up the whole time I'm there.
if a clinician is tasked to determine whether someone is in a catatonic state or engaging in selective mutism, how would one distinguish the two?
So, from my understanding, which I'm saying may be incomplete, selective would be something that there sounds like a sense of volition, or it might be only in some situations with some people, which would be inconsistent with catatonia. When I would hear selective mutism, my mind would go towards more of an avoidant or a uncooperative behavior, whereas catatonia I think of as completely out of the person's control.
So, as an example, for about selective mutism, selective mutism is another way to say just selectively mute.
I think so, but as I've mentioned, you're really pushing the boundaries of what I feel confident talking about.
That's okay. But somebody, and I'll use, since you've done research on that, children and adolescents, a child who, a parent interacts with, say, hey, what do you want to have for lunch today? They may be engaged. And then suddenly a ball gets thrown, something gets broken, and that same child is going to be very quiet, not moving. In that instance, that could be, in that scenario, potentially selective mutism.
The way you described it, I would have gone more with highly distractible, or as opposed to selective mutism, which I think can bifurcate either into a volitional component where the person's choosing not to address some topic, or could reflect something where the person's so distressed that they're really unable to meaningfully engage. So in both cases, it would be different than a condition that is ubiquitous and beyond their participation.
Understood. If someone were to engage in some conversation, if you were reactive and receptive, and not engage in others, would that be indicative of catatonia?
No.
Someone choosing to lie about something, is that indicative of or evidence of disorganized speech or thought, or something else?
Well, by definition, since you said they choose to lie, that would be different.
And when you talk about schizophrenia, when you say they have schizophrenia, does that mean they are always psychotic?
No.
Can you explain?
So the different symptoms, the domains that we talked about that are part of psychosis, like hallucinations, delusions, and disorganization, those wax and wane over time. They wax and wane with treatment, they wax and wane with situation. So a person can be highly psychotic when they're off medicines, they have schizophrenia. Then, after a period of 3 to 6 months of adequate doses of a good antipsychotic, their psychosis can wane. They still have schizophrenia. Then something bad happens in their life, the medicines haven't changed, and they become psychotic again. They still have schizophrenia. Then their psychosis goes away because you raised the dose or the thing passed, and they still have schizophrenia. Schizophrenia is a trait, something that is like height. You have it, you have it. Psychosis is a state. It comes and goes, like being happy or sad or being sick, right? Like having the flu. So there's a state and there's a trait. Schizophrenia is a trait. Psychosis is a state.
Okay. And psychosis on its own is not exclusive to schizophrenia. True?
True.
and it's actually scattered across a number of disorders,
Yes.
which one of them could be substance use, as one example.
Yes.
And obviously schizophrenia and so forth, right?
Correct.
Now, psychosis, just having psychosis by itself doesn't necessarily indicate schizophrenia either, right?
That is true.
You look to the other factors to make this comprehensive opinion as far as the diagnosis.
Yes.
And frankly, all diagnoses, is this fair to say? You tell me if I'm wrong here. All diagnoses is basically a clinician's best efforts of determining what they believe under the facts that they've been given, what could be the situation here.
All diagnoses in psychiatry, yes. In other fields of medicine, there are conditions and disorders that have much more concrete diagnostic criteria. But in the realm of psychiatry, it is, as you said, the constellation of signs and symptoms, the chronology, and your best judgment.
And so, when forming a diagnosis, it really depends on what facts a clinician has.
Yes.
Incorrect facts could lead to an incorrect diagnosis.
Yes.
In fact, incomplete facts could also lead to an incorrect diagnosis.
Yes.
Somebody, out of curiosity, somebody who does not need, as an example, does not need antipsychotic medication, or, you can couch it in any other disorder we want. But if, let's say, they don't need the medication and they start taking the medication that they don't need, can something happen to their brain for taking a medicine they don't need?
Yes.
And what are some of the things that can happen?
Are you restricting that to antipsychotics or more broadly?
We can start off more broadly.
Objection relevance more broadly.
Sustained.
Okay, we'll stick with antipsychotics.
So antipsychotics have both desired effects. That's what you'd sort of call the effect of the drug, the therapeutic effect. They also have effects that are related to the medicine's intended mechanism of action, the thing it does, but they're undesirable, so those are side effects. A good example with antipsychotics are that we want the medicine, for example, to block dopamine receptors, as I mentioned earlier. That seems to attenuate psychosis. But when we give someone a drug, it goes everywhere. It doesn't just go to the cells, the neurons, and the brain structures we want. It goes everywhere. So it also blocks motor cells, parts of the brain that control movement, that also have dopamine receptors. And so you'll get some motor impairment, some problems with stiffness and coordination. And that happens to a greater extent if you don't have the illness than if you do, in general. So that's one example. Another example is our very best medicine, a medicine called clozapine, has a very broad spectrum of activities. It does bind dopamine receptors, but it also binds serotonin receptors and acetylcholine receptors. And so by the time you get to the dose you need and the binding and what's called antagonism, the blocking of dopamine receptors that's desired, you've also created, for example, a very high degree of acetylcholine antagonism. So that individual will not be able to move their bowels, urinate, they'll salivate, they may develop seizures at higher doses. All of these other things kind of come with the molecule. So desired effect, less psychosis; undesired effect, all those other things.
And someone who may not need, for example, clozapine, and I know you've done profound work on clozapine, from my understanding, and does that create a dependency on that particular drug for someone who originally didn't need it in the first place?
No, if you don't need an antipsychotic and you took it, it would be very unpleasant, and you would not become dependent on it. Now, you might experience changes as you came off it, just as your brain adapted to it. Your brain would adapt to its absence, but I wouldn't call that dependence, because you wouldn't seek it, you wouldn't need escalating doses to get the same effect, you wouldn't experience difficulties after that initial adaptation, and you wouldn't go back on it.
Makes sense.
Is it brand name Zyprexa?
That's a different medication. That's olanzapine.
Olanzapine, different from clozapine.
Different than clozapine.
Clozapine.
Yes.
Okay. Thanks.
And now, going to substance use, you would agree that substance use with somebody who may be predisposed to schizophrenia can exacerbate the symptoms of schizophrenia?
Yes.
And you talked about, I think you indirectly said 6 to 7 for drug users, but you also heavy users, for example, let's specifically go to cannabis. It's a 4-time multiplier for heavy use, correct?
So yes, in short.
And versus moderate, which is much less, a 1.4 modifier.
Yes.
And so a heavy user would have nearly 3 times as much of a modifier compared to a moderate user.
4 versus 1.4, so 2 to 3 times the risk, yeah.
Okay. And so substance use can impact dormant schizophrenia at an increased rate?
Yes.
And you would expect this in somebody who had no outwardly mental health symptoms at all until someone started to heavily use marijuana?
So I think this is a part that is not a straightforward yes or no. May I sort of explain? So I think of this both in that prodrome period, but also once someone has manifest. There's a level of symptoms that fluctuates, as I mentioned earlier, with treatment state, but also with environment. And environment can include exacerbating factors like exposure to cannabis. So during that prodrome, we know that people have change in cognition, change in function, change in social engagement. Some even have a brief psychotic episode where they sort of tip into psychosis briefly and come out. If one may have that in the context of cannabis use, but one can have it without cannabis use. So there's this kind of background variation, and then you put cannabis on top of that and it'll layer. Similarly, someone can have schizophrenia. They might have a mild, a moderate, or severe case that can be treated and kept in check, but then you layer cannabis or another drug on top of that, and it changes the balance, the homeostasis. You've got disease, you've got treatment, and now you add another thing, and you tip the balance.
And so, you talked about cannabis use disorder. You talked about cannabis-induced psychotic disorder to a degree. Is cannabis-induced psychotic disorder and schizophrenia mutually exclusive, or can they coexist?
So I think they can coexist when the cannabis is present, and it can be difficult to distinguish in that moment which is contributing, the most or predominantly. So someone can clearly have schizophrenia, and if they're using, cannabis 3 times a day, every day, they can't go without it. They seek it even though it's a problem. You would say they have cannabis use disorder, but they can also have schizophrenia, especially if you've established that diagnosis previously. So, for example, if someone had a period of several months no cannabis, and their symptoms continue. You would say this person has schizophrenia. Then they resume their cannabis use, and they use it to the extent that would meet criteria for the disorder. Most days or several times a day, seeking it, even when it's causing problems, etc. Now they get both. That's to be, I would distinguish that from the person's using a lot of cannabis and they're psychotic, and you think it's cannabis-induced psychosis or cannabis use disorder with cannabis-induced psychosis, and then the cannabis stops. You wait more than a month, maybe you even wait 6 months, and they have the psychotic symptoms, the loss of function, all those other things. With no cannabis, you would say they had the cannabis use disorder. They even may have had cannabis-induced psychosis. They also clearly have schizophrenia.
Understood. So in a given scenario, if as a clinician you're looking back, so a patient comes to you and says they've had psychotic episodes, but they've also conceded to you or admitted to you that they are a chronic, heavy user of marijuana, let's say multiple times a day. In that scenario, with those psychotic symptoms, certainly you would say one possibility is cannabis-induced psychotic disorder. True?
If they're currently using, and if I had no information or evidence that they had been psychotic in the absence of cannabis, then that would clearly be on the table. Okay.
And then you would also look to the post-effects of when they're off cannabis for a period of time, you would surmise, okay, schizophrenia. True?
If they had been off cannabis for at least a month and the symptoms persisted, then yes.
You said at least a month. Why say at least a month? Is there I think you said earlier up to 6 months. What was the 6 month?
No, I just earlier, just now,
yeah.
I said, because it's a six months for diagnosis for. So, I was just using it like technically you could do it after a month, but I was saying, if the longer they persist being psychotic in the absence of an exacerbating or potentially causative thing like cannabis, the longer that persists, the more certain you become that it's schizophrenia. Technically after a month, but don't forget you need that 6 months without something else to make the diagnosis. So if they had the diagnosis, they'd had 6 months, then they do the cannabis, then they stop the cannabis, you can rule out the impact of the cannabis. But in the beginning, you do need 6 months for the symptoms to exist, to make that diagnosis, remember the chronicity, and in order to rule out the cannabis, you need 1 month.
And the reason why you don't rule out cannabis-induced psychotic disorder coexisting with schizophrenia is because schizophrenia, you must rule out drug use as a cause, as one of the criteria, right?
One of the criteria is there's nothing better explaining it, right? That's when I say, not a tumor, not an infection, not a drug, right?
Right. And so coexisting is still something that's common in the psychiatric community with multiple disorders.
It is.
Is there any type of psychotic disorder that is mutually exclusive from each other? So, for example, schizophrenia and bipolar, cannabis-induced psychotic disorder and bipolar. Sorry.
Yeah, I really wish you'd use the mic.
I'll just do this one.
Okay.
Yeah.
Thanks.
Did you get the first part of the question?
Yes.
So, schizophrenia and bipolar, cannabis-induced psychotic disorder and bipolar. Is there any type of psychotic disorder that is mutually exclusive from the other that cannot coexist with each other, or anything within that spectrum can still coexist with each other?
I'm trying to go through my mind and look for an example, but generally we just layer them on.
Okay. And that's based on the factors that you are given by the patient.
Yes, and that a person can meet criteria for multiple things. Now, practically, there's so much overlap that sometimes we use a phrase called Occam's razor, you may have heard, where you look for the single best explanation. An example of that would be someone who has limited emotional range. They don't enjoy anything in life. They don't have a lot of activity in their life. Well, that can sound a lot like depression until you learn that they have all these other things for schizophrenia, and you'd say it's better explained as the negative symptoms of schizophrenia than having schizophrenia and depression.
And is there a limit on the number of disorders that can be piled on?
Not that I know of.
So someone can have anxiety, bipolar, depression, schizophrenia, cannabis-induced psychotic disorder, cannabis use disorder, and the list can go on and on.
But you wouldn't. I mean, again, there's nothing that says you can't, but you wouldn't. In practice, what you would do is look for a disorder that is the best explanation, and you would only add a second one when it doesn't fit within that. As an example, we think of anxiety disorders, and we haven't talked about anxiety in schizophrenia as a criteria. But imagine what it would be like to go through life wondering, when are you going to start hearing voices again? Even if you're not hearing them now, always having to decide, was that in my head or was that actually outside? Are people out to get me, or am I just being self-conscious? So it's a very anxiogenic state. And in fact, if you give an anxiety scale, we have these evidence-based scales that rate how bad is the anxiety. You give an anxiety scale to people with schizophrenia as a population versus people who have a diagnosis of generalized anxiety disorder. That's their primary psychiatric illness. Anxiety is actually higher in schizophrenia than if anxiety disorder was your only diagnosis. So I wouldn't personally say you have schizophrenia and generalized anxiety disorder. I would say you have schizophrenia, which has a huge anxiety component.
And this sounds all very complicated and complex. I'm just surmising from all this, right? In the community, in the field, it's very complex and complicated.
I guess.
I mean, so for example, a layman like me, it's difficult for me to go do that versus, yourself, who have many, many years of experience in academia to go through. You would need your advanced area to really channel this in.
I think it's helpful to have the appropriate training to be in the role. Also, we tend to treat symptoms. And so, for example, if someone's very anxious and they have schizophrenia, I'm going to treat their psychosis and their anxiety. I might not get all caught up in whether I give them a second diagnosis in their chart or not.
And that's a fair point. Your focus is to get them better and get their symptoms to subside.
Yes.
You're not so much focused on throwing a label on it.
Right. I do need to have a label because that gives me information about treatment and prognosis. But once you get into these sort of finer points of, do I need an independent anxiety disorder or an independent affective disorder, the relevant part becomes, what's the best treatment? So as an example, sometimes people will say, well, if the person's not experiencing joy and they have schizophrenia, why not give them an antidepressant? And the answer is because it won't help. It works in depression, but if you have negative symptoms of schizophrenia, antidepressants, there's no evidence that they help. So that's a point where it would be really important to not be agnostic to diagnosis, but to say what the symptoms I'm experiencing are best described by schizophrenia, because in that case it's going to dictate treatment.
And you were talking about focusing on symptoms. That would be more in a clinical setting, fair to say?
Yes.
Is there an area in the field that focuses more on identifying versus treating the symptoms? So is there going to be clinical and forensic approach?
I'm not sure what you mean by forensic. I was going down a sort of a research side. You're not talking about research.
I was kind of combining two different concepts. Are you familiar with forensic psychiatry?
Yes.
And what is that?
It's the intersection of psychiatry and law.
Okay.
Is that different than clinical psychiatry?
Yes.
How so?
Generally, forensic psychiatry is it's a fellowship people do. So you need specific training. One should have specific accredited training in forensic psychiatry by the American ACGME, the American College of Graduate Medical Education, and the focus there is understanding how psychiatry and the law intersect. So it's things like all of the complexities around involuntary care, involuntary commitments, how mental health and the law intersect in a whole bunch of
We're going
ways.
to have forensic experts here, so why don't we address those questions short of those persons?
And when you say psychotic symptoms, we're talking about symptoms of positive symptoms such as active hallucinations, active delusions, and so forth. Is that true?
Those are examples of psychotic symptoms, yes.
Okay. And then,
Let me stop you for a second. I'm going to stand up and stretch. Just take a stretch break.
okay.
Okay.
I'll stand up and stretch.
Thank you. Okay. Off the record. Try to cool off the room a little bit.
And on the topic of psychosis, we're talking about psychotic episodes, psychosis. Generally speaking, when you talk about schizophrenia population, how about the prevalence of psychosis in the population?
So it would be higher, since as you pointed out, psychosis is a broader term. And if you bring in the psychosis that could be part of anything, I don't have a specific number, but I would estimate that it would be more like 4 to 5%. And I say that because there's psychosis contextually. People who come out of surgeries often have a brief psychotic episode in the hospital. People with Alzheimer's disease can have psychotic episodes. People who have bipolar disorder or major depression can have psychotic episodes at the depths or high points in their illness. And people who have intoxications can have psychosis. So all of those together, I could imagine or estimate would add a few more percent.
And it's 4 to 5% of the overall global population?
Or at least the population in the U.S. But I don't know that it would be terribly different.
Okay.
And that's probably a bit high, maybe 3.
I think you said about 0.5% for schizophrenia in the global population. Is that fair to say?
Yes.
Okay. That's why I'm trying to frame the same question in a similar context for psychosis.
So I would really need to go do a proper literature search to put real numbers on that. But I would say it's going to be a fraction of the people with Alzheimer's disease and various other, frontotemporal dementia, Lewy body disease, there's psychosis. A fraction of the people with bipolar disorder are psychotic, although it waxes and wanes. There's a smaller fraction of people with major depression, but major depression is a much more prevalent disorder, so a small fraction of a larger number. And then you have all the people with situational psychoses related to an exposure, which could be a medication like anesthesia, or could be a substance like a medication with a psychotic side effect like Parkinson's disease medicines or drugs of abuse. And when I put that all together, I'm estimating that it might go 0.5% of the world's population has schizophrenia. It might be 2 or 3% of the world's population that experience psychosis.
How does that, in your opinion, number change, if you know, based on changes, societal changes such as drug legalization or changes in environment or changes in lifestyle? Has that number for psychosis changed?
So I don't know. Again, I would need to do a proper search to have data. The one piece that is relevant is there's been an increase in the number of cases of cannabis-induced psychosis presenting in ERs. Again, these are brief, time-limited, generally 24 hours. But there's been an increase in cannabis-induced psychosis presenting in emergency rooms, especially in settings where it's become more prevalent and legalized, without a concomitant change in schizophrenia.
Understood. And as you said, you cannot attribute any one single cause to schizophrenia. It's too difficult to do that. Is that
You could not do that in a specific human being, no.
Okay. And with cannabis, with marijuana, I know you did your research with cannabinoids. You would agree that the potency of cannabis has changed over the years?
Well, not something that I've researched. It absolutely has. That's, I think, clear from a variety of sources in the literature. The cannabis that's available today is very different than the cannabis that was available 30 years ago.
How so?
It's more potent. It's been concentrated and cultivated, and there's more ways to get it and higher doses available.
How does that impact in the psychiatric field? Does that play any role with anything?
I think it complicates our practice in that you're going to have more cannabis-induced dysfunction and more cannabis-induced problems. And there is a perception that it's relatively safe, which I think can exacerbate or complicate problems people present to us with. And so it's harder now to say, well, the cannabis isn't related because the profile of what it does has changed with the potency.
And so, as a clinician, and you have a patient coming to you with what you believe to have prodromal indications, you wouldn't want them to be engaging in drug use, or specifically marijuana use?
I would not.
Not even mildly?
Not even mildly.
Okay. Not even in the form of, for example, a vape form?
No. I would say to them, this is a pretty serious time in your life where we need to figure out what's going on with you. In one possible future, you're fine. In the other possible future, you have schizophrenia, and we need to make plans for that. You need to stop using so we can figure out which one of those futures is yours and act accordingly.
And in the psychiatric field, or rather in the medical field, doctors are trained to focus on the worst possible scenario versus just assuming the better scenario. Is that fair to say?
I would say we're trained to assess all of the possible outcomes, starting with the most common, but then working our way to increasingly less common, weighting those. With the more serious it is, the more you might move it up in the differential to rule it out.
So, for example, in the medical field, someone has a tumor. A doctor would say, we need to think of it as could be cancer. Let's hope it's not, but we need to think of it could be cancer.
Not 100% of the time. I'm not an oncologist, but I do interact with all the other department chairs, and there's plenty of benign tumors where a dermatologist will look at it and say, that's a whatever, and then they'll decide what they're going to do about it. They might biopsy it, but they'll tell you they know exactly what it is, and they're going to treat it like that. Again, they might biopsy it just to be sure, but
they can't discount the possibility of cancer.
Check out the scope of the scene.
Okay. You would also agree that cannabis use can push a person over the threshold of expressing temporary symptoms?
Yes.
And that people who use cannabis go on to develop lasting schizophrenia.
Some do, as do some people who don't use cannabis.
And that could be user-specific.
I'm sorry, could you?
Person-specific. I mean, you said some do and some don't.
Right, so may I clarify what I mean?
Yes.
So as I mentioned, 99.5% of people who've never used cannabis never go on to have schizophrenia. But 5.5% of people who've never used cannabis go on to have schizophrenia. If we look at people who've used cannabis, 99.3% go on to not have schizophrenia, 0.7% go on to have schizophrenia. The difference is 1.4, but still the overwhelming majority of people who've used cannabis don't ever develop schizophrenia. So there's no way for me to say what's going to happen to you because you're either using or not using.
And you would agree that you're not saying people with schizophrenia are violent individuals.
No, in fact, so there is an increased incidence of aggression in people with schizophrenia. However, given that they are such a small fraction of society, the overwhelming amount of aggression and violence in society is by people who don't have schizophrenia, and in fact people with schizophrenia are also statistically more likely to be the victims of violence and aggression than their peers.
And actually, when you talk about the DSM, it even talks about how those with schizophrenia, it's uncommon for people with schizophrenia to engage in random attacks.
It is uncommon. I mean, it can happen, as you can imagine, with a delusion, but it's not something that I don't spend my days, worrying about with my patients.
And so, when you see that, do you see aggression in schizophrenic patients?
Yes, you can.
Okay, but when it talks about random attacks as being uncommon, you talk about coexisting. Could there be another attributable cause for why a person who may have schizophrenia engage in a random attack?
There can be many reasons, right? So, as an example, I don't want people to, and what I want and what's real may not be the same, but I don't want to leave here with people thinking that you got to be scared of people with schizophrenia. By and large, they're just trying to get by. Right? They're really just trying to get by. Shoes over socks, On the other hand, when somebody with schizophrenia has a delusion that makes them feel like their safety is threatened, or, for example, a very, I wouldn't say common, a specific kind of delusion called Capgras syndrome, where the person believes that everyone around them has been switched for a body double, a doppelganger. That specific delusion raises our threat level, because once you believe that the people around you are not your mother, your father, there's some demon or some imposter, your tether to ethical behavior becomes released. And so when a patient says to me, I don't think my mother is my mother, I think she's been switched, all the red lights go off for me, and I say, were you thinking of poking her with a knife? And it sounds like a random question, but there are specific delusions like Capgras syndrome or having doppelgangers or feeling threatened that definitely raise the probability of what will look like random aggression. It's random to me and you, it's not random to them.
Can you clarify that further? What do you mean by that?
So it may look like a random act of aggression because we're not in that person's head. We didn't hear what that person just heard. Maybe they heard somebody say, "Get him," and they go after someone. It's random. It's a random passerby. But to them it wasn't random. They heard, "Get him." Or they may believe and I'm going to use real examples, trusting that none of my patients are ever going to see this and realize that I was talking about them. But someone may believe that a 4 on a license plate has a very specific meaning, and that 4 is threatening. So they might do to someone getting out of a car with a 4 on the license plate. They don't know that person. To the rest of us, that was a random act of violence. But in their world, that person had a 4. And as they know, 4s are dangerous. So that's what I mean by an apparently random act of violence can have a specific cause if your grip of reality is so distorted that you feel threatened, or you're tethered to experience, your hearing, your feeling, your smelling is unrelated to what everybody else can see, feel, and smell, that your actions appear random, but they can be defensive.
And individuals in that scenario, that environment, can still engage in volitional and voluntary actions.
So all these things can exist. Again, they wax and wane. The extent can change. Again, I've had patients who say, they live with their parents, they're convinced that their parents are swapped. We've all made an agreement that they're not going to do anything to those people that are living with them. We don't have a better alternative. We don't have another place that person can live. They're not doing anything right now that allows me to hospitalize them. But the person's kind of getting up every day, they're getting dressed, they're maybe even doing some chores around the house. And they're walking around in this constant state of feeling like they're living with strangers who've been swapped with their parents. And I worry.
And you're not saying in those scenarios that those individuals would disassociate from their own actions, are you?
Can you please, I'm not sure what you mean by disassociate from their actions.
So, for example, you talked about somebody with a number 4 on the license plate. Somebody choosing to grab that license plate and tear it off, they would be still capable of making that decision to tear that license plate off.
They could. They might be doing it for reasons that don't make sense to the rest of us. From their perspective, they're defending themselves, but yes, they decided to defend themselves.
And then I'm going to wrap it up shortly, but I want to move forward to the genetic predisposition we talked about.
The what?
The genetic predisposition we collectively, I guess the more passively, we're talking about. You are talking about increased risk with genetics. True?
Yes.
And the level of the familial level can depend on what risk level someone may have. So
The distance genetically is proportional to the risk.
That is specifically couched on the premise that what that family member has is, one, correct in the diagnosis. I mean, we're assuming, one, that was a correct diagnosis, and two, that actually exists, right? Meaning that is, we're not only diagnosed correctly, but the symptoms and everything, that's actually happened. So even if they were diagnosed, they could be diagnosed incorrectly, but they were diagnosed correctly and they still manifest those symptoms. That would be premise on that.
Can I start with the first one? You're assuming, when you do these association studies, you're assuming that Aunt Barbara actually had it, and so does Jimmy, right? They both have it. Whether they're manifesting right now, that's the part I'm not following. It doesn't really matter.
Okay.
It's just it's the trait, not the state, that matters.
Good rhyme there. Yeah. And so, great-grandma, who may have something, extended aunt along the extended line, that can affect the risk multiplier?
Yes.
But that's not the only basis. There's a number of factors to look at just among that, right? There's many reasons to determine whether someone is predisposed to schizophrenia.
Again, there are many risk factors. One is genetics. The other is birth history. The other is, exposures. All of these things weigh in. And so the pertinence is when we're doing an initial or even an extended diagnostic injury, we're trying to understand what's happening. You can say, gee, a lot of these things look like schizophrenia. This person hasn't functioned well, they've got some odd experiences, they've lost all their friends, and by the way, they have a maternal aunt who had schizophrenia. So you kind of go, oh, schizophrenia moved a little bit up on my differential. It's still, you're not going to make the diagnosis based on that, but it became a little bit more likely in your mind because they have a family member who has schizophrenia.
It also would require that it be known as well, right?
Which would require it be known, and they still need to meet criteria. You don't ever give somebody like a pass on one of the criteria because they had an uncle. They're still going to meet criteria to get the diagnosis, but as you're working up all the different possibilities, you're incorporating the likelihood that this is where you're going to land. And so, an aunt, and by the way, mom had a really bad infection, and turns out dad's not really dad. Initially, dad was a different guy who, died while the kid was 2, and, all these things. And you say, yeah, you know what, we're stacking up risk factors here. I'm more worried that this is heading towards schizophrenia than I might have otherwise been.
And so, globally speaking, how someone is diagnosed with a mental illness, let's say schizophrenia, is that dependent on the specific country or region, or is it uniform globally?
So it varies by psychiatric illness, and not to go too far down a tangent, but one of the reasons that I really love working in schizophrenia, the reason that it pulled me into psychiatry was this disorder, is that it just looks the same everywhere. There are cultural contexts where there were things that people had in Japan that we don't diagnose, and there are things we diagnose that they don't diagnose. But schizophrenia, it looked exactly the same. And in my mind, that meant this is something that is as real as a stroke or a tumor because it's agnostic to the language or the culture. Schizophrenia is schizophrenia no matter where you go.
And the DSM, that's specific to the United States?
It's a United States thing, yeah.
Okay. Is there different types of manuals in other countries?
Yeah, everyone, pretty much everyone else uses the ICD-9, or maybe now it's the ICD-10, which is basically it has its own criteria for these things. They're very similar, so there's good harmonization. And I'm guessing there are probably some countries around the world that adopt the DSM, but there's some that wouldn't.
Okay. And drug abuse, going back to risk factors, drug abuse would be a risk factor, one risk factor for schizophrenia?
Yes.
Okay. One more, please. Does somebody who is not fully forthright in their background or their inpatient in their background or their drug use, does that complicate diagnosis?
Yes. Yes.
In what way?
Well, you can't incorporate information that you don't know, or if it's wrong. So if I say to someone, have you ever heard someone talking when no one was around, and they say no, I don't really have a way to prove that they're lying. Now, I might observe something we call responding to internal stimuli. Right? So the person may say, I never hear voices, and then you see them kind of going. So we can, but that's not going to help me with, did you hear voices last week? So if someone obstructs me from having information, I can't make a diagnosis.
That's fair. And just to kind of finish off these questions, just going back to your overall approach, I appreciate all of the information you've provided. It's been, and I can tell you that your academic involvement has been profound. You, generally speaking, I know you're primarily academia. Do you You don't testify regularly in a criminal setting, do you?
I do not.
Okay. How many times have you testified in a criminal setting?
Maybe 2?
Is this one of them?
Yeah, 2 or 3.
We joined the club. And just to be clear, now the defense hired you in this case?
Yes.
You would be hired by either side?
Yes. As a matter of fact, there was one time I worked for both the district attorney and the public defender in the county of Los Angeles because they both agreed they just wanted to know it was very similar, kind of like, we just want information. We don't really have a dog in which way it goes. And so they both worked with me.
Perfect. And so when were you contacted to be involved in this case?
Feels like about 8 months ago, but I would need to search my records. I could be off by a little bit.
Last year, this year, do you recall?
It would have been before 2026, I believe.
And then, specifically speaking, you were asked on direct about what you reviewed. You didn't review anything about this particular case. Nothing about the defendant.
No.
Nothing about any specific facts related to this case.
The only thing that I have is, and it's in my report, is that I'm aware that other doctors have examined the defendant and that they had opinions, but I don't know anything about him.
Beyond that, were you given parameters or limits on what to review?
Yes.
And what were those?
To really focus on the etiology and pathophysiology of schizophrenia and the contribution, the extent to which there's a contribution from cannabis.
And so you're not here to give any sort of opinion or insight as to, frankly, anybody in this room.
No, I mean, in terms of anyone in this room's mental health, yeah, I'm not going to comment on anyone in the room's mental health.
Yeah, and you would agree that, I think you addressed it on direct, it's not really proper to diagnose somebody without really seeing it.
You would need either an interview or extensive access to records, but you'd have to have some form of evaluation to make that diagnosis.
And that's why when you were asked by the defense why you said no, that you were not here to give an opinion.
Right.
Okay.
Correct.
And lastly, your function here is specific to schizophrenia and your academia as it relates to schizophrenia.
Objection misstates existing.
Okay. And your opinions and what you testified to today is limited to your experiences, what you've read, and your limits on your background.
Objection misstates testimony. He's a qualified expert.
Yeah, sustained.
Nothing further.
Okay, great. Thank you, Mr. Keon. And so then, Mr. Hutchinson, any retry to
Focus on, be very focused. Given that people with schizophrenia often don't believe they're sick, how is it they end up in emergency rooms if they don't feel they're sick?
Objection overruled.
So most often, they're brought by someone, family, police, some other, the EMS. Occasionally, the person will come in complaining about something that we then realize is a delusion or a hallucination. Someone might show up saying, you need to get this guy out of my head, or I've got these wires that must have been embedded in me because I feel electricity. So, but most often, people present to an emergency room or an acute setting for care because a family member brought them or forced them.
Given the age that schizophrenia often begins, how common is it for the parents to be the person bringing them in?
Very.
question, are there circumstances for people who are on the street, in the public eye? Is it common that they are brought in by law enforcement at times?
Also very common.
Are there people who could fall through the cracks? In other words, they have housing, so they're not in public eye, but they don't have family who is involved.
So I know I keep saying common to everything, but these things can all exist in the same person over time. And yes, unfortunately, mental health, psychiatry, is sort of quartered off from the rest of medicine. And unlike the rest of medicine, where when someone lacks capacity to give informed consent for a life-saving intervention, we simply act with benevolence with a surrogate decision maker or through the authority of the government or the health system to intervene. When it's mental health, we have a totally different approach, which personally I believe is not appropriate. But if you were to say to someone, if you were to say this individual is choosing to live on the street, risking all sorts of terrible things, as long as they're not going to die tonight, that's their right. And you can't bring them in. And they can just exist like that to the chagrin of their families and everyone else, because we don't force treatment in psychiatry unless there's imminent danger to self or others.
I want to clarify one thing the prosecutor said. He said when we're talking about psychotic symptoms, and he mentioned delusions, hallucinations, disorganized thoughts, are negative symptoms psychotic symptoms?
They're part of schizophrenia, for sure, and I think some people would call those part of psychosis. I think you get a little more variation there, but technically, yes.
We'll talk about goal-directed behavior. If I go to the bathroom, is that goal-directed behavior? If I walk to the bathroom and use it?
Yes.
If I pick up a bottle of water and have a drink, can that be described as goal-directed behavior?
Yes.
If I walk to the kitchen and get food, could that be described as goal-directed behavior?
Yes.
If I log on to my cell phone, like I do every day, could that be described as goal-directed behavior?
Yes.
If a person engages in goal-directed behavior, does that mean they cannot have schizophrenia?
No.
And sir, you spoke about people with schizophrenia being able often to do habitual goal-directed behavior. What did you mean by habitual?
So, you can describe yourself like getting dressed, right? Getting dressed. It's something you do every day. You've done it for decades. It's got a certain order to it. What goes under what. That doesn't take a lot of planning and sort of calculation about how to execute on that. And so someone can be very impaired and still be able to do those things. Even though if you took that same individual and said, Ron, I'm going to give you a set of instructions and I'm going to ask you to do something you've never done before. I want you to go downstairs, outside, take a right, and then walk 10 blocks and make a left. That might be way out of bounds, right? Even though they could get dressed.
Have you seen people with schizophrenia who have jobs?
Many.
Have you seen people with schizophrenia who are actually in school when you're seeing them?
Yes.
Now, the prosecutor was talking about conditions existing at the same time. I want to go back to cannabis-induced psychosis. You described it as rare. What did you mean by rare?
Cannabis-induced psychosis? I mean, it happens in, I would guess, less than 5% of people who use cannabis. So 95% of people who use cannabis never have an incidence of cannabis-induced psychosis. Less than 5% do, so rare.
And although there's a 30-day cutoff, typically how much time does it take for the psychosis to resolve in cannabis?
48 hours, 24 to 48 hours for most.
So, sir, if a person has no underlying mental disease, you can assume that fact, and I use cannabis, and I have a psychotic episode, and it resolves in 48 hours, that would likely be cannabis-induced psychosis.
Yes.
If a person with schizophrenia who is suffering from psychosis and hallucinations, delusions, uses cannabis and it exacerbates the symptoms, is that cannabis-induced psychosis or is that something different?
I think you could use the term cannabis-induced psychosis or cannabis-exacerbated psychosis, but if they weren't psychotic before because they're well-treated and stable and they use it, they become psychotic, then it's cannabis-induced psychosis on the background of schizophrenia.
No, my question is, if I'm actively psychotic due to schizophrenia...
I'm sorry.
I may have misspoke. If someone is experiencing symptoms of schizophrenia, hallucinations, delusions, and they use cannabis and it exacerbates their symptoms to some degree, okay, what would you describe that as?
I would use that term. I would say this is a person with schizophrenia who had a cannabis-exacerbated level of psychosis. I wouldn't give them a separate diagnosis. If they showed up in the ER, we say, this is a guy with schizophrenia. We know him, right? We've met him before. He happens to have cannabis in his pee, but, you know, he still has schizophrenia. Treat as if schizophrenia.
So, and I know you could use the term induced, you know, interchangeably. Some people could use it to mean exacerbate, but as that psychotic disorder, cannabis-induced psychosis, that is when a person without an underlying mental condition, the cannabis is what induces the psychosis.
Objection. Go ahead.
So, yes, when you're diagnosing cannabis-induced psychosis, you're saying that that's the cause of what's going on right now.
I have nothing further. Thank you, sir.
All right, briefly, we have a minute. Do you have any questions, Mr. Keon?
I do.
Okay.
Am I confined to a minute, or?
Yeah, basically. I mean, we've had this witness up here long enough. I mean, go ahead.
I have maybe 5 or 6 seconds. Okay, so someone who's consuming cannabis and gets under a psychotic state with cannabis, you say they generally resolve within 24, 48 hours. If they resume cannabis, can they get into another cannabis-induced psychotic episode again?
Yes.
And that would resolve again?
Yes.
And then they can consume cannabis again, and that would resolve again?
Yes.
Okay. And that can also be, as you said, coexisting with a predisposition to schizophrenia that's on the back end.
Yes.
And going with, now, bipolar disorder itself, that doesn't increase by itself the risk of schizophrenia, does it?
So if you have it in the family, it does. It's kind of like a twofold increase. Having someone with bipolar disorder, like a first degree, instead if your parent has bipolar disorder, I think you're 3 times more likely to have schizophrenia as opposed to 10 times more.
Got it. And then with respect to schizophrenia itself, now you identify schizophrenia as a trait. Now psychosis within schizophrenia is a separate concept within schizophrenia, true?
Yes, that's a symptom, like a state, as I said.
And that's why people with schizophrenia can still go to work, still go to class, and be fine.
Right. Just because you have schizophrenia doesn't mean you're psychotic right now.
Right. It's the psychosis is what the issue that you have to treat.
Yes, and people with schizophrenia also have, as I mentioned, significant cognitive difficulties, so it's also very common to have schizophrenia, have your psychosis completely treated, and still be unable to work.
And so someone with schizophrenia, also consuming a heavy user of marijuana, for example, can still be under a psychotic episode derived from cannabis, but also still have schizophrenia.
I would have used the word exacerbated, but yes.
Okay, thank you. I have nothing.
I have one question I have to clarify.
With prostate use, you can.
Use the term predisposed. Okay. If I have a grandmother who has schizophrenia, a grandfather who has it, I may be predisposed to schizophrenia, correct? genetically predisposed.
You'd have a higher risk.
But being predisposed does not mean I'm actually going to get it.
No, it doesn't mean, it's not a foregone conclusion. It just shifts your risk probability.
There are people who are predisposed genetically who never developed schizophrenia.
As I mentioned, you can share 100% of your DNA with someone with schizophrenia, and half of you will not develop it.
Okay. Predisposed to schizophrenia is different than prodromal schizophrenia. That's
right. So I'm sorry. I guess predisposed is not a term I should use. It's really, you have prodrome, which means things have already gone off the rails. Something's already changed, right? In that period of 3 years, the person's already experiencing difficulty. Other than that, what we talk about is relative risk, right? You are not your predisposition in the sense that it's already a done deal, but rather that you have an elevated risk level such that the probability you will develop it is higher. But no one is predestined to have it. There's no one we can say at birth, this guy's going to get it.
Thank you, sir. I appreciate it.
Right. Thank you, Mr. Hudson. All right, Dr. Siegel. Thank you. That's the end of your testimony.
Thank you very much.
Have a safe trip back to Los Angeles.
Thank you.
Thank you.
Have a nice day.
I appreciate it. Ladies and gentlemen of the jury, it is time for the afternoon break. It'll be
I feel like they were going to give him a warm send off there. Dr. Siegel, thank you for joining us today. Judge McAdam was going to give him a nice warm send off there. All right, you guys, that's gonna wrap it up here. We are going to call that a day. I thought that doctor was very, very educational. I think he poked a lot of holes in the state's whole theory that this was cannabis induced, that Carlos was not going through a psychosis, wasn't going through a psychotic break, doesn't have schizophrenia. I thought that here, let me move this. Let me just come over here. I thought that that doctor alone, I think, to me, really hurt the defense. I'm sorry, hurt the state. And I think by most of what you guys have been talking about, we've been talking about it, I think you kind of agree with that statement. So, class is over. Yes, you are being dismissed. You are being dismissed for the day. All right. So thank you guys for joining us today. Thank you to our mods. Thank you to Aaron. Thank you guys for. We have 97 likes. Before we end the stream, take a moment. Let's see if we can get to 100 likes. If you hear my voice and you are not in our chat, just take a moment and let's get to 100 likes. So that we can end the day on a high positive note before we finish. Can we get to 100? If you hear my voice, please get to 100. If you don't do it for us, do it for Super Bowl. Oh, look at that! Oh yes, that's a good girl. Let's see if we can get to 100 likes for Super Bowl. Super Bowl is asking, please get us to 100 likes. Oh, 98. We're at 98. We need 2 more. Who's going to be 99 and who's going to be 100? Can we get to 100 likes? Can we get to 100 likes? 2 more. Come on, 2 more. If you can hear my voice, please. Please get us over to 100 likes. We need 2 more likes. 2 more likes. Who can do it? Who's going to get us over? All right. Well, while we wait for there's 99. All right, 1 more. We need 1 more. While we wait for our 100th like, if you take a moment to give us that 100th like, tomorrow we are going to be back on the New Mexico Isaac Apodaca. That is day 1. I hope that you join us for that. And we went down to 98. We were at 99. Somebody took their like away. Who takes a like away? Who takes a like away? Oh, we're back up to 99. All right, 1 more like. Do it for Super Bowl. Did we hit it? I'm only seeing 99. Nosy Rosie saying we hit it. Oh, there we go. 100. Awesome. Thank you. Thank you so much, guys. Really appreciate that. All right. With that, I'm going to say goodbye before we go back to 99 likes. Thank you guys. Really appreciate you you joining us. Again, thank you to our mods. Thank you to Aaron. Tomorrow, Isaac Apodaca, day 1. So we will see you tomorrow at 10:15 Eastern. They're starting at 8:30 local time, which is New Mexico. And we will see you guys. We'll see you guys then. All right. Take care. Have a great night. See ya. Oh, and we'll pick back up on Carlos. Don't worry. We'll definitely pick back up on him once Apodaca ends. We'll focus back up on Carlos, and we'll watch some more testimony. So have a good night, and we will see you. We'll see you tomorrow. Okay. Bye, guys.